A hearty good afternoon to all. Myself, Dr. Ketki Joshi, on behalf of SOGS Team 2324, welcome you all for today's live workshop, Pearls of Ultrasonography Imaging in Obstetric and Gynecology. To begin with, I request Dr. Meena Gunjotikar to present her talk on FCM in iron deficiency anemia.
Good afternoon. Today I am here to present about FCM in management of iron deficiency anemia. Anemia is a global burden, affects around 800 million children and women globally. It has a 1620 million people living with anemia, and more around 50% are pregnant women. According to definition, less than 11, less than 10.5 are the CDC guidelines of anemia. And total iron requirement during singleton pregnancy is 1000 to 1200 milligrams. Consequences of iron deficiency anemia. Maternal anemia contributes to 18% of perinatal mortality and 20% of maternal mortality, including the countries like India. And diagnosis of iron deficiency anemia includes routine all investigations, CBC, HB, RBC count, hematocrit, retic count, serum iron, TIBC, etc. and peripheral blood smear. Anemia Mukt Bharat Guidelines 2018, Anemia Management Protocol for Pregnant Women. Mild anemia, moderate anemia includes the first level of treatment. If no improvement after the first level of treatment, then according to severe anemia treatment, we will start. It has immediate hospitalization if in the third trimester of pregnancy, and IV iron sucrose and FCM by the medical officer. Indications of parenteral iron therapy. IVRM therapy is superior to oral iron in terms of speed and absolute extent of the rise in HB and replenishment of iron stores. The main indications are failure of oral iron therapy and non-compliance or intolerance to oral iron. And contraindications are gestational period less than 12 weeks. Evolution of parenteral iron. History of intravenous iron. US FDA approval timelines are here. Parenteral iron structure, iron and carbohydrate complex. It rapid release of large amounts of labile free iron leads to toxicity and adverse drug reactions. This allows the administration of large doses of IV iron complex, complete replacement dose in a single dose in a short time duration. Properties of an ideal parenteral iron. What are these? These are ideally it should be more than 100 kD molecular weight, complex stability should be high, half-life should be long, and pH should be neutral, osmolality should be isotonic, and test dose should not be required, and maximum dose we can give. Parenteral iron preparations. Type 1 complex is strong, type 2 complex moderately strong, and type 3 is weak. Examples are type 1 FCM, iron isomaltose, ferrum oxetol, iron dextran. Moderately strong are iron sucrose, and weak are ferric gluconate, iron citrate, and iron sorbitol. Parenteral iron preparation. These are first generation iron dextran, high and low molecular. Second generation ferric gluconate, iron sucrose, and third generation are ferric carboxymaltose and ferrum oxetol. Limitations of parenteral iron preparation. These are associated with severe allergic reactions and intramuscular doses are required. Then according to iron sucrose, multiple doses are needed. For ferrum oxetol only approved for treatment of iron deficiency anemia and chronic renal disease. Advantages of ferric carboxymaltose. It overcomes the low dose limitations of iron sucrose. Type 1 dextran free robust iron with long half-life. Stable complex, does not release non-transferrin bound iron. Structure similar to ferritin, deposited easily in retic. Low antigenicity and no test dose is required. These are the ideal qualities of FCM. These are best suited for real-life clinical usage, like short infusion time, iron is released slowly, avoiding toxicity and oxidative stress. Structure is similar to ferritin. So FCM 750 milligram, 3D dose, dilution and duration. So calculate dose iron requirement based on the existing HB and weight of the patient. So it is easy to calculate according to less than 10 and 10 to 14 gram HB and according to weight of the patient. Dilution and duration of administration. Adverse drug reactions are considered potentially related to long duration of infusion and dilution of FCM in high volume saline beyond recommendation provided in prescribing information. And possible mechanism is long duration of administration, and excess dilution may lead to destabilization of iron complex that may cause adverse reactions. And monitoring it should be done when staff trained to evaluate and manage anaphylactic reactions should be ready, an environment where full resuscitation facilities are available. And place in therapy, majority of Indian patients with anemia are between 35 to 70 kg and HB level less than 10 gram per. 750 milligram 2 doses 1 week apart will be sufficient. And so it is flexible to doctors to administer. Clinical evidence, FCM 750 in the management of iron deficiency anemia. So the conclusion is 2 750 milligram FCM infusions are safe and superior to oral iron in increasing HB levels in iron deficiency anemia patients with inadequate oral iron response. So FCM administered as 2 infusions 750 milligram given in 1 week apart was safe and effective and should be considered a treatment options of iron deficiency anemia in subjects who have an unsatisfactory response to oral iron as well as those are intolerant to iron. So these are the clinical studies. One conclusion is FCM is safe, well tolerated and associated with improvement in HB, and fewer FCM infusions were required to reach the target iron levels compared to other IV iron preparations. So global evidence of FCM in pregnancy. Current evidence highlight data, FCM usage in pregnancy with maximum HB rise of 5.5 grams and ferritin rise of 180 micrograms. So this is the data. So no adverse effects in terms of perinatal and neonatal outcomes were observed in newborn of women who received FCM during pregnancy. Neonatal outcomes were not adversely affected due to FCM. So blood transfusion versus parenteral iron. During NCR, trial of FCM is to be given before blood transfusion in women presenting with severe anemia. Studies from India identify that PPH is the major indication of blood transfusion in obstetric practice. And IV iron such as FCM can be alternative to blood transfusion, especially in women at high risk of transfusion-related reaction. So conclusion is FCM is an ideal parenteral iron, requires no test dose, low risk of hypersensitivity reactions or anaphylactic reactions. FCM dose are calculated based on body weight and HB deficit. Most of Indian patients are of weight 35 to 70 and average of HB less than 10. These patients will require a dose of 1500 milligram and lower dose may not be therapeutically useful. A significant increase in hemoglobin and blood indices were seen in various trials with FCM 750 mg compared to other treatment. So FCM 750 mg offers flexibility to doctors to choose various parenteral iron preparations for treatment of iron deficiency anemia. Thank you.
Thank you, Dr. Meena. It is my pleasure to introduce our guest today, Dr. Kuldeep Singh sir, a master trainer in the field of imaging who has achieved many accomplishments in the field of ultrasonography and has authored several books on ultrasonography. Sir is a consultant ultrasonologist at Dr. Kuldeep's Ultrasound and Color Doppler Clinic since past 25 years. He has delivered more than 600 lectures and has been invited faculty for ultrasound courses nationally as well as internationally. He has trained thousands of students through various training programs organized by Sono School. He's been awarded Imaging Science Award at AICOG Delhi. It's our proud privilege to have you here, sir. I'm sure it is going to be an academic feast for all of us. On behalf of Solapur Obstetric and Gynecological Society, I request Dr. Virkar sir to please welcome Dr. Kuldeep Singh sir. We have a variety of cases for the workshop today, both obstetric as well as gynec. The moderator for the workshop, Dr. Ajit Gandhi sir and Dr. Dabde sir, I welcome you and I request you to please take your seat. I also welcome Dr. Sumit, who is coordinator of the workshop. We'll start with the cases very shortly. I request Dr. Kuldeep Singh, sir, to please address the gathering.
Hi, good afternoon, everybody. It's my proud privilege, and thank you so much for inviting me here. Thanks to Dr. Vitkarza for making all this possible. We were earlier planning last year, but then the rain gods decided, no, it's not going to be 23, it's going to be 24. So we had to postpone it for this year. Thank you, Dr. Meena. Thank you, Dr. Ketki. Thank you, Dr. Praveen Karisa. Thanks to all the seniors over here, Dr. Melincha. We've been meeting in so many of these meetings. So it's always good fun in terms of interacting, in terms of arguing. What we're going to be doing in today's workshop is, do we have the machine walas, and if they can get a machine here so that then at least I can start showing it. We're going to go with the basics. Do we have the GE people here? If they can get one of the machines here, and if it's possible to switch it on, then we can take it on from there. So, okay, then if we, we'll do that. We'll do that. What I'm going to be doing is, it's going to be lots of interaction. So whatever we're going to be doing over there on the screen, you want me to show something again, you want to ask something, and if the baby obliges, it's not you want me to show the NT and the baby decides to be, the spine has to be anterior, so we'll wait patiently and watch. Otherwise, any cases that you feel like they need discussion or anything, I have my laptop, we can easily show plenty of videos. So feel free to stop me anywhere you want and ask me any number of questions. There is no problem at all. If before starting off, if I can know how many of you doing your own ultrasounds, or almost everybody is doing it? Almost everybody is doing it. In terms of anything specific that you want me to demonstrate on the machine, is there any particular knob? Because I always start from knobology, that's most important. So is there any particular knob that you feel that it needs to be, okay, how are we going to be doing this? I can show it to you on this machine, and then every machine is going to be different. We can never say this is the control panel of a particular machine. So we are going to go according to that way. Any specific question regarding knobs, most welcome. And it's going to be a to and fro interaction. I'm going to be learning few things from you, you're going to be learning few things from me. So we'll start off with, and anybody of you can keep on answering, is what do you feel are the basic 2D knobs that you really need to be looking at? If I start with just the 2D, anybody can just answer, or if we can have a few mics floating, for which are the basic 2D knobs that you feel are the most needed? I'll start off. Depth is the most needed. Anything else? Gains. Gains can be of two types. If I'm using a particular area, what do we call that as? Where there are multiple knobs over there? That's the TGC. And we have the overall gain. Then we have the incident beam. That means how much are the ultrasound waves that are going to be going inside the patient's body. How can you control that? That can be controlled by sector. It's basically that's going to be controlled by power. And usually you can have the power from 10 to 100%. Never use 100%. Use 80 or 90%. That's what we call the incident beam. Then we have the reflected beam. So the moment the beam is going to be reflected back, how are you going to be able to really change that? With the sector, with the gains, with depth, with focusing, and in terms of zoom, what do you feel is a better zoom? A live zoom or a frozen zoom? Live zoom. I'm a little hard of hearing. Plane pe aake na mere kaan band ho gaye ji, so that's how we're going to be interacting. So a live zoom is much better. The same way, you click a picture on your mobile and then you keep on doing like this and the face doesn't come out clearly. So that way you need a live zoom. You can always have two types of zoom. One is going to be an overall zoom, that is the center of the image becomes bigger, or you can have a box zoom where you can take the box any way you want and you can have that, right? Which is the first case we have, so that then we'll start off with that and then we can plan it. How many? 12 weeks pregnancy. And how many of you doing your color Dopplers regularly? All of you? Almost everyone, right. So I'll start off with first doing the NT scan, but we'll keep on interacting. So if I don't get answers, I'm going to be a little worried because they've closed me here. मुझे ये ना लगे सारे के सारे घर वापस चले गए हैं. So मुझे आवाज़ें आती रहनी चाहिए, otherwise I'm going to feel as if everybody is left and everybody is getting bored. So we'll start off with the first case. If any history has to be given, we can. अभी पहन लेता हूँ, मुझे क्या दिक्कत है? कान पे लगाओ किसी? कान वाला है तो कान वाला दे दो, उनको दो। आप एक काम करो। मैं करता हूँ। ना ना, मेरे को माइक दे दो सर। मैं माइक नहीं दे दूँ। सर मेरा पगड़ी ला दोगे आप? नहीं। हेलो। नहीं सर नहीं आएगा। मैं तभी कह रहा हूँ। आप एक काम करो ना सर, मेरे को माइक दे दो, मैं कॉलर माइक लगा देता हूँ। ना ना, आप कॉलर माइक दे दो, अदरवाइज एक सेकंड। ये सब काम चल जाएगा। I'll wear this. This is most.
निकाल देता हूँ। आपका कोट में ले लो।
मैं इसके ऊपर पहनता हूँ, नहीं तो फिर कोट उतार लेंगे। नेक्स्ट स्टेप वही चलेगा। अब भी देख लेते हैं।
थोड़ा इधर थोड़ा कंपलसरी।
नहीं, वहाँ पे भी जरूरी है। फर्स्ट क्लास।
बीच में अगर आपको
वही करेंगे, वही करेंगे। मैंने सबको बिजी रखना है। We going to make sure for the privacy of the patient. No sir, बिल्कुल ठीक है। और ये दे दीजिए, ये भी दे दीजिए। For the privacy of the patient, we are not going to be showing the patient as such, but we first going to be showing the machine as such. ठीक है? That's fine now. Can everyone hear me?
Yeah, but everyone would like to know what machine you are using.
The camera over here on the machine so that then I can show them the knobs to start with. अभी ना एक सेकंड एक काम करते हैं। आप बेटा ऐसे लेटे रहो, अभी ऐसे लेटे रहो। Are you all able to see the monitor over there? What is being shown over here?
Yeah, we can see only the
Perfect.
monitor.
So let's let the camera come, and meanwhile I'll show. Basically, we always have a marker on the machine, on the probe as such. So it could be in the form of, let the camera come, but otherwise I'll show you.
You please tell him.
external camera you.
If we can have the external camera, I can just show them for a few minutes and then we can. आप जब फोटो खींचेंगे ध्यान रखिएगा पेशेंट की फोटो नहीं आए, ठीक है? हाँ, privacy रखनी है ना उनकी। जी। It's basically the probe is going to have in terms of an indentation, it's going to have in terms of a light or a colored mark over here, and that corresponds to, can you see where my arrow is moving on the screen?
Yes.
This is going to be. So if I'm going to be looking at, let's say a SAT section, what is this going to be? Cranial or caudal?
It's cranial.
This is going to be cranial. And then I need to be turning my probe, and if I need to be having transverse, what would this be? Right or left?
Patient's right side.
This is going to be the right side. So it should appear as if the patient is lying on the screen over here. Sorry for sounding basic, but that's the first thing that we always need to be watchful about. we are looking at an overall gain. That's the overall gain that we are increasing. Can you see this over here?
Yes.
The arrow, this is the gain over here which you can increase or decrease. Are we
Yes.
able to see that? That's the gain. You can have the TGC going up and down, whichever way. I don't know whether the cameras come here or not, but yeah, you can see over here. So it's basically, that's the monitor, that's the touch panel. शुरू हो गया वहाँ पे?
No, we are not able to see.
Are we able to see what the camera is showing in terms of the complete machine?
That's picture in picture. Can you make it little more wide, the image on the screen?
आप
Yes,
एक-
yes, perfect.
Yeah. So what you're seeing over here, this is the touch screen. And can you see these 5 knobs over here?
Sir, what machine, what model is this?
This is which machine? I'll have to see. Volison S10 Expert. That seems to be which company? That's the GE machine, Volison GE.
Yes, sir.
Right. So whatever you're looking at over here on the touch screen, all these things are going to be changed with this. So if you see the second one doesn't have anything, so we're not going to be able to do anything with this. The TGC far field, I click again, I'm going to be going on to the TGC near field, we can increase or decrease that. The same thing appears on your machines as well. In might be a separate format. Then you can always interchange it, usually not to be done. You can do it like this, usually not to be done over here. So this is how you're going to be, this is the basic. You can see over here on the touch screen, can you see where my finger is moving?
Yes.
These are the presets. These are the presets. You always and always have to make sure that you are the boss. If you're looking at these presets, those have been created by the company walas, and it's not necessary for getting an optimum image. Might be you would like a separate image, I would like something separate which would be much better for me. So never go in by, okay, these are the set standards. You see on your own what is best for you and follow that. That's the best way to do it. There are various other advanced ones, the dynamic range, the grayscale. As in when we go on, I'm going to be showing you all those, but this is how we're going to be following it up. In terms of, there are 3 things that you need to be careful. One is resolution, one is general, and one is penetration. Out of the 2 probes, the transvaginal and the transabdominal, which one has a higher resolution? TVS or TES, A or B, which has a higher resolution? The TVS has a higher resolution. Which one of them has a higher frequency?
TVS.
The TVS has a higher frequency. Which one of them has a greater penetration? TVS or TES? TES. So that is how we're going to be looking at the expense of frequency, at the expense of resolution we are. So does it mean we do not need to do a transabdominal? We can only do a transvaginal and be comfortable about it, even for a gynae scans? You need to be always be very, very careful. It always has to be a transabdominal first and then a transvaginal, so that there could be an ovary which is quite higher up. There could be multiple fibroids and they could be giving trouble. So you need to be very, very watchful for these things so that you do not make a mistake. Right? Are we clear on those things? So in terms of how many of you have a transperineal probe? You haven't asked your company walas to give you a transperineal probe?
No separate transperineal probe.
And a transabdominal probe, how many of you have?
Everybody.
So everyone has a transperineal probe as well,
Yes.
right? Is there anybody who can help me out by taking this transabdominal probe out so that then I can, how can we take that out, Ji? So that then I can explain them.
आप वो बाहर ही निकालना है क्या?
हाँ जी, प्रोब अगर बाहर निकल आएगा तो मैं प्रोब लेके, और या बाहर वाली मशीन के पास प्रोब है तो मुझे वो दे दीजिए, बाहर वाली मशीन है, नहीं तो इससे निकाल लेते हैं।
निकाल के देना है या सर वेट?
आप मेरे को दे दीजिएगा तो मैं बाहर एक बार ही लेके जाके दिखाता हूँ। अब इसकी जरूरत नहीं होगी कैमरा की, अब आप ये बाहर ही ले जाइएगा। और अभी लेकिन ये वापस चाहिए होगा जी। हाँ? Basically what you're going to be doing is, I'm just getting the transabdominal probe so that then I can explain how you're going to be making it into a transperineal. Because that's the question I ask everybody. Everybody says, no, the company walas haven't given us. You wear a glove, you put on jelly on this, put your probe on this and deglove the probe. So it becomes a transperineal or a translabial probe. Where are the conditions where you need to do a transperineal or translabial scan? If you're looking at for somebody whom you cannot do a transvaginal scan, this is the best way of getting a very good picture. Sometimes in the third trimester, few patients are not very comfortable that doing a transvaginal for the cervical length, this is a very good way of doing it. How many of you have a transrectal probe? Everyone now, because the transvaginal probe can be used for that. For looking at the scar thickness, if any one of you has a linear probe, that is always the best, because you can really see nicely how much is the muscular healing, how much is the fibrous healing. So we'll now start off with doing a patient. And just remember to keep asking questions so that there is no confusion. Thank you. Thank you so much. ये एक बारी लगा दीजिए, इन्हीं को दे दीजिए. What's the LMP of the patient so that then we can feed in the LMP?
Sir, we have done that.
LMP fed it? Perfect. It's 10th of January. You need to be doing NT scan. From what weeks to what week should an NT scan be done, Ji? From what weeks to what week should an NT scan be done?
11 to 13.5.
11 to 13 weeks and 6 days. Not at 10 weeks and 6 days? It should not be. And not at 14 weeks, not at 14 weeks and 1 day. And the crown rump length should be how much? 45 to 84 millimeters. We're just starting. I hope now whatever is showing on the screen is going to be coming over there, because I can't see the screen from here. Always and always first start off with the eyeballing. Do you feel the orientation is correct? Can you see the bladder here? Is the orientation correct?
No.
What I'm doing is I'm holding the probe ulta, so that's the best way. This is how it should be, right? What are we? So first, always and always do an eyeballing. I would have preferred to have the bladder a little more full, but otherwise it's fine. This is the bladder. We're looking at the uterus over there. What area is this that we're looking at over here? This is the placenta over there. What is this area that we're looking at over here? This is the cervix over there. Now, when you're supposed to be, zoom kahan pe hai ji? Zoom ye hai. So this is what I'm doing, an overall zoom. If I need to do a box zoom, this is how I can. Now, how's a box zoom helpful? If I'm going to do an overall zoom, it's going to come out from the center. But if I need to be looking at this area, where I need to change it, let's presume this is the area, set kaun sa? This is how I have. I'm not saying that this is what I'm trying to see, but this is how you can possibly do it. So that is how a box zoom is extremely useful and helpful.
Sir, the image is appearing too bright on the screen here.
It's going to appear too, not to worry, we'll just reduce it because that's how it's going to be. Now is it okay?
Better.
I'm looking at the fetus over there. Is it okay? Coming fine? Can I see the baby jumping? Can I see the nuchal translucency? Should I measure it? Should I measure the nuchal translucency? It's coming out so nicely over here. Why should I not measure it? Because of the?
You are not meeting with any of the criteria.
Because we are not having any of the criteria. So now the second question is, what are the criteria? The first criteria is the zoom is not proper. Second criteria is it's not a mid-sat section. Third criteria is I'm not able to look in at the midbrain, so that is why I'm going to be holding on. Now, if I'm supposed to be looking in at the crown rump length, should the crown rump length also have some sort of magnification or any size would do? The Crown rump length, you need to be doing a measurement when the fetus occupies 60 to 98% of the screen. It has to be a relaxed position and you should be able to look in at the neck area. That's the best way. So you should be able to look in at the neck area specifically, because what you're going to be doing is, if it's not and you're taking it from the side, you're going to be making a mistake. What is the measurement of the NT which is regarded as normal or abnormal? Less than 2, less than 2.5, less than 3. It always depends on the weeks of gestation. So for the weeks of gestation, I need to be measuring the crown rump length properly. That's how I need to measure it. The crown rump length, perfect. That's how. ठीक है जी. So I'm going to be taking from the top of the head. ये set button. Sorry, I'm getting used to the machine. And this is how you're looking at 55 millimeters, 12 weeks and 1 day. That's how you're going to be measuring it. So now all the measurements that need to be done have to be done according to the crown rump length. Now for the nuchal translucency, what is the magnification that you're supposed to be looking at? It should occupy the cranium and the thorax over there. The cranium and the thorax over there should be there. You should not be seeing the abdomen. You should not be seeing the limbs over there. Abhi kar lete ji. Are we all able to see something over here? What is this portion that you're looking at? What is this? This is the nasal bone. What is this that you're looking at anterior to the nasal bone? The nasal skin. What do these form? What sort of a mathematical thing they form? That's an equal to sign. That's the nasal tip over there. What are you able to see over here? What is this? That's the midbrain. What is this that you're looking at over here? That's the brain stem. You're looking at the IT or the ICT, the intracranial translucency. You're looking at the cisterna magna. You're looking at the occipital bone, and you're looking in at the nuchal translucency. How do we take the measurement? Just the measurement. Okay, no, I don't want the specific measurement. Right. So you just need to tell me, because is this measurement correct? For everything you all are saying no, कैसे काम चलेगा? फिर अब कैसे नापे जी? Is this okay? So that's how you're supposed to be measuring only the translucency. Only the black area has to be measured. It has to be a sharp image. You're not supposed to be involving the skin over here. And the maximum distance anywhere between the occiput and the heart is to be measured. Neutral position by looking at liquor between the lower jaw and the thorax over there. You're looking at the brain stem. You're looking in at the intracranial translucency. You're looking in at the cisterna magna. Any questions on this? Please let me know so that then we can keep on explaining. Then it's not always that you're supposed to be looking at just at the nuchal translucency, this scan. There are plenty of things that you can see. What am I seeing over here? What sign is this? What sign is this, Ji? The butterfly wing sign. So what am I seeing over here? This is the choroid plexus. I'm looking at the bone outside completely, and that's absolutely fine. What all have I excluded in terms of that these anomalies are not there? There are 3 of them specifically. I've excluded acrania, I've excluded anencephaly, I've excluded encephalocele. Perfect. So that is how we are looking at just by seeing this. What am I seeing over here? This is the fetal spine over there. Once you're looking at the fetal spine, and especially because you've seen the intracranial translucency, what have I excluded here? That we're not looking at an ONTD. I'm not looking at an open neural tube defect. We're looking at the heart. Can we go into the first trimester cardiac? There. Can we zoom the picture more? There we go on to zoom. How many chambers are you able to appreciate there? Sorry, you want to do something, Haj? We're looking in at those are the 4 chambers, 1, 2, 3 and 4. This is the spine. So the chamber closest to the spine is the left atrium. The anterior-most chamber is the right ventricle. So this is left atrium, left ventricle, right atrium, right? And we are looking at these valves over there. So why is this valve closed over here? Is it supposed to be like that? Is it normal? Is the tricuspid valve supposed to be a little lower than the position of the mitral valve? That's the correct way. How I remember is as if the moderator band is pulling the tricuspid valve, though that's not the case. So for looking at tricuspid regurgitation, I am going to be looking at over here. Where should I keep this? Like this, or like this? A, B, or C? I need to be keeping it here so that there is one of the sample volume limb is in the ventricle, one is in the atria. Can we take a tracing? बिल्कुल ठीक है, थोड़ा सा वो कर दीजिए ताकि वेव्स और ऊपर आ जाए. रुको मैं एक बारी वो भी कर देता हूँ. इसको वेलोसिटी को चेंज कर दीजिए ताकि वेव फॉर्म्स लंबी लंबी आ जाए. कोई नहीं, लेट मी जस्ट ये वाला. ना बच्चे, या तो मेरे को बताओ क्या कर रहे हो ना, नहीं तो फिर कंफ्यूजन हो जाता है. रुक जाओ ना, आई हैव टू, या तो उसमें करो ना, साइमल्टेनियस में चलता रहे, तो फिर साइमल्टेनियस वाला करते हैं, साइमल्टेनियस वाला करते हैं. अभी रुक जाओ, पहले मुझे वो करने तो WF ना बेटा, ये कैसे चेंज करेंगे? हाँ, PRF. Now that's how I wanted it. Now I'll just show that to you how we're going to be. Now we're looking at, this is the systole over there. We are trying to look in for this wave over here. Do you feel this is tricuspid regurgitation? Why is it not tricuspid regurgitation? Because this value is not more than 60 centimeters per second. What happens is, if you're looking at the chamber over here, let me just first show you the heart over there and you'll be able to understand that much better. I'm looking in for tricuspid regurgitation. This is the right ventricle, this is the right atrium. So when the atrium contracts, the blood flows from the right atrium to the right ventricle. So it's going to flow towards the transducer. So on the baseline, the flow is going to be up or down. When I'm looking at a duplex Doppler, this is flow towards the transducer, so it will come above the baseline. Now when the ventricle contracts and there is regurgitation, and if you find the blood flow going behind, if there's a regurgitation, you will find it more than 60 centimeters per second below the baseline. That's why that's what you need to be seeing before you make a diagnosis of tricuspid regurgitation. Anything that's not clear, please feel free to ask. Can we go on to the normal first trimester? And this is the time when you can see the limbs much more clearly. There, you can see the complete limb over there. I hope the image is coming out okay, not very bright.
Yes, sir.
You're looking at the feet over there, you're looking at both the limbs, complete limbs. Sorry, I'm so used to looking at the TGC knobs over there. This is on the touch panel itself. You can see the feet over there, no club foot over there, no gross club foot deformity. You're looking in at the hands over there. Now we're going to be looking for the ductus venosus. So don't stop at just looking at the NT, the NB. You're supposed to be looking in for structures as well, because that's what's going to be very, very helpful. Now what am I trying to see over here?
DV.
This is the ductus venosus. And the baby decides to jump that very moment. ना बच्चे यूं करते हैं तो वो क्यों नहीं हो जाता, वो इससे होगा?
That is, yeah. That is simultaneous.
ना simultaneous नहीं चाहिए. The moment I press this button, I want कि दोबारा फिर से वैसे ही आ जाए. रुको, मैं भी कर अभी देखता हूँ. Every machine has a different sort of setting. So the left one.
Yes.
Let this baby be a little more silent, and then I'll. That's the ductus venosus. The ductus venosus waveform is going to be which alphabet shape? That's the baby jumping. Yeah, this is what I wanted. Perfect. Naughty baby jumping. The moment I start off with some music, the baby decides to dance. This is the umbilical vein that's coming. What vessel is this that you're looking at over there? This is the hypogastric artery which forms the umbilical artery. So if you're looking in at the urinary bladder, you will be able to see the two hypogastric arteries, and that basically means you're able to look in at that there are two umbilical arteries over there, and it is a triple vessel cord, not a double vessel cord or not a single umbilical artery. That's where the umbilical vein comes on, and this is where you're going to be again looking at the ductus venosus, just waiting for the baby to be a little more calmer, and then we look in there. The moment I switch on the sample volume and the baby decides to jump. This is what you're looking at, the M sort of a pattern. I don't need a. You can either have the Doppler invert. Can we have the Doppler invert again? You can either have, this does not mean that there's a reversal of flow. So this is basically one, yeah, we can again invert it. It is not that this waveform is correct and this is the inversion or this is reversal, not at all. So what you're looking at, that's the M sort of a pattern that you're looking at. This is ventricular systole, this is ventricular diastole, and this is atrial systole. Out of these three, what am I interested in? A, B, or C? We're interested in only the C over here. And what is regarded as normal in the NT scan? Either positive flow, or even if it is absent, it is regarded as normal. But the moment I see a reversal is when I'm going to think of that this could be a soft marker, again looking in for increasing the chances for Down syndrome. If I'm looking at a problem in the ductus venosus, if I'm looking at a thick NT, I'm always going to be a little more skeptical, even if I've done a CVS or an early amnio, and if that's normal, that there should be no anomaly of which system? The cardiac system. So if there is a thick NT, there is a tricuspid regurgitation, and there's a reversal or an absent flow in the ductus venosus, be very, very careful. There could be a cardiac problem. What else do you feel has to be seen in this patient in the 11 to 14 week scan? Anything you want me to repeat again? I can do that, Ji. Dr. Vikas, सारे चले गए हैं या हैं अभी?
We are waiting for the uterine artery Doppler.
Uterine artery. Now, the moment you're trying to look in at, again, ideal would be a little more partially full bladder, but you're supposed to be seeing the internal os. You're supposed to be looking at the cervix over here, and always first try and look in for on the 2D. I'm tilting my probe one, or I can just slide my probe onto the right side, come back again in the center, slide my probe to the left side, and we're going to be looking at the vessels over there. You're looking at the cervix. Now I'm going to be insonating this, and you're going to be telling me just by the waveform what sort of a thing can I have. Just a little bigger sample volume. That's it, that's it. Now if I'm looking at invert, kahan se hoga sir? Invert. And how can I have the baseline a little lower? If I'm looking at this portion, I'm looking at a notching over there. Is this normal or abnormal? In the NT scan, is notching normal or abnormal?
We disregard that and go ahead with PI measurement.
We're basically interested in the PI measurement. Otherwise, if I'm looking at a notch in my anomaly scan, I'm going to be skeptical, irrespective of the PI. But if I'm looking at in the NT scan, I'm not going to worry. And as correctly sir said, we're going to be looking in at the PI measurement. Can we have the PI measurement? You can either have an automatic PI measurement, or you can have a manual one or a semi-automatic. You're looking at the PI measurement, and I'm trying to see the PI measurement is 1.40. I'm looking at the right side and the PI measurement is 1.40. I'm comfortable. Should I send the patient back home?
The other artery.
We need to be looking at the other side as well. And when I'm looking at the main right uterine artery, the main left uterine artery, what am I supposed to do with both the values? I'm supposed to be calculating the mean of both the velocities. So I'm going to add them up, divide by 2, and if I'm doing an abdominal scan, the mean uterine artery PI in the NT scan should be less than 2.35. If I'm doing a transvaginal scan, it should be less than 3.10. Normally a ballpark figure of 2.50 is taken. There are various ISIOC guidelines, FMF guidelines, where you can feed the values and they can give you the percentiles as well. Whichever you're following is comfortable.
Just one request to the delegates.
Ji.
We all have these papers here, so those who want to ask questions, because of the scarcity of the mics, you can write down your questions on this paper and hand over that to me. Thank you very much.
I'm looking at an artery over there. Is that fine uterine artery?
We should be looking at the peak systolic also.
We look at the peak systolic, that's more than 50 centimeters per second, but what I've done over here is, I've taken a measurement before it has crossed the iliac. Ideally speaking, after it's crossed the iliac is the right way to be looking at the uterine artery. There, if you see that over there. I've taken it in the cervical area as such. ऊपर कर दो बच्चा। If you're looking at this sawtooth appearance, again, that's not a good way. We need to be carefully evaluating it again. Though this does not mean we're getting a clear reading, we need to be watchful for that. I'm just trying to show you all the things that we can miss out or we can make mistakes on. That same sawtooth appearance, because I've now taken a proper waveform, it's there. But if you see, in terms of the left uterine artery, the PI value I'm getting is 2.81. On the other side, it was 1.40. So do you feel it is normal or it is abnormal? The mean uterine artery PI. The mean uterine artery PI is going to be around 2.1, which is absolutely fine. This is what we're trying to look in for as the spiral artery invasion. We're supposed to be looking at the radial artery invasion in the anomaly scan, and that's when the final thing comes on. So why are we so skeptical about seeing the uterine arteries in the 11 to 14 or in the NT scan? Why not just after the anomaly scan? What's the benefit of seeing in the NT scan?
Predict preeclampsia and IUGR.
Because it's going to be a good screening one, and in terms of starting the treatment, it's always better to do it before 16 weeks, because after that, starting aspirin, ecosprin, or whatever you are going to be doing is not going to be that beneficial.
Sir, there is a request
Ji?
that could you demonstrate the premaxillary triangle and complete hard palate and celiac trunk, and how do we exclude the bladder extrophy?
Right. Now, can we see this premaxillary triangle? I'm so glad the question was put up when the baby was seeing up. If you see over here, we're looking in at the eye sockets. What is this that you're looking at inside? That is the lens. And that's how you're looking at the premaxillary triangle. And in the triangle, what we're trying to look in is at this portion, the base. So if you're seeing this, you're quite comfortable that you're not looking at trouble. When you see this, it's always a little doubtful whether is it because of the nasal bone or is it because of the zygomatic process. So always and always see this view as the equal to sign to look in for the nasal bone. Can you all see the nasal bone over here with the equal to sign? That's how you're supposed to be looking at. The other thing that you're supposed to be looking at for the bladder extrophy, if you're seeing is, this is the reverse K sign. In this case, the baby is obliged and I'm able to see in the bladder, so I'm comfortable. Can you see the bladder over here? That's the bladder. I'm looking at both the umbilical artery or both the hypogastric arteries. Are we all comfortably seeing that? But otherwise, to look in for bladder extrophy, this is the best way to see. If you're looking at this sort of an angle, if you're looking at this going this way, you are quite comfortable, because in a bladder extrophy, it's going to come like this and then join like this. So this way, I'm comfortable, even if I'm not able to see the bladder, that it should be present, and I'm looking at the anterior abdominal wall as well clearly. I hope that those answers the question that everyone was asking.
Yes,
Any
yes.
other?
Celiac trunk.
That I honestly don't see too often, so I won't be able to show that as such. I don't see that quite often, Ji. Anything else? Sorry, I don't see that quite often, so that's why I'll not be able to demonstrate it that nicely. Anything else anybody wants me to, I'll be able to.
Thank you for all the demonstrations, sir.
Thank you, Ji. By the time they're changing the patient, we'll come and just check in for a few of the other formats. Tissue दे दीजिएगा. Thank you, Ji. Thank you so much. सब बिल्कुल ठीक है. 36 weeks, perfect.
9th month के 2 हैं, वो पहले खत्म कर लेंगे.
बिल्कुल ठीक है जी. बिल्कुल
उसके बाद
ठीक. That will be ideal. That will be ideal. By the time they're changing a patient, and basically that's going to be in the third trimester, that's around 36 or 35 weeks. When we see a nuchal translucency measurement as, let's say, 2.8 or 2.9 millimeters, should we terminate the pregnancy? Why? That means it's Down syndrome, doesn't it? आप लोग हर चीज के लिए तो ना करें सर, क्या हो रहा है? That's, we're not supposed to. We're not supposed to be panicking. We're not supposed to let the patient panic. So that is why you need to be very, very careful. Fine, more than 2.5 millimeters, or we never take a ballpark figure, it's always the calculations that yes, this is the crown rump length, this is the patient's age, this is the patient's descent, this is how the NT measurement is. So there is what is an a priori risk? For somebody, let's say, who's 25 years old, what would an a priori, I'm not asking for the value, but what does an a priori risk mean? That what is the risk for any patient, let it be 20 years old, let it be 35, let it be 40, before starting a scan, what is the risk is an a priori risk. And if the NT is going to be thick, the risk is going to get better or the risk is going to worsen? The risk is going to get worsened. So that is how you're going to be deciding what has to be done. In terms of what is the blood test that can be done along with the 11 to 14 week scan, just the blood test. That is the double marker, and the double marker consists of PAPE and free beta HCG, the beta HCG, right. Should we just tell the lab walas to do the report differently and we should be doing the ultrasound differently, or should we join them? And if we join them, what do you call that test as? That's a combined test, right. In the second trimester, how many of you getting a triple test done? I'm so glad. Triple test is defunct now, we do not do. It has to be a quad test. Then NIPT is a diagnostic test. Phir na kar rahe sare. NIPT is also a screening test. That's not a diagnostic test, right? It's going to always give a risk. So what are the diagnostic tests that can be done? CVS and choreocentesis that can be done, right? So that is how you're going to be looking at. This is how you're going to be mentioning it. There are various ways of testing it. You can have a combined testing, and let's say the risk comes on less than 1 in, let's say the risk is 1 in 1,000, 1 in 1,100. What should you do next? There's one school of thought which says do a quad test. The latest school of thought says nothing needs to be done. Now the risk is, let's say, 1 in 90. It's less than 1 in 100, 1 in 90. What should be done? A CVS or an early amnio has to be done. Now we come on to the intermediate risk, that is from 1 in 100 to 1 in 1000. What has to be done? You can either do an NIPT, or the guidelines say you can do a quad test. And in the quad test, if the risk is more than 1 in 250, meaning 1 in 270, 1 in 300, 1 in 800, they say you do not need to do anything, but that is because their standards go on for the NHS. In a country like ours, where the patient is going to get so petrified, usually an NIPT is done. And if the risk is less than, for instance, 1 in 240, 1 in 230, the risk is high, they say we should be doing a invasive test, we should be doing an amniocentesis. In this whole process, if there's anything I can help out with, do let me know. Or if there's any other questions you have, if there's any other case you need to discuss. How many of you are members of Sono School, Solapur ji? Do we have a few of them? 1 or 2 of you there. Fine. We don't have too many members. So in fact, I had put up a case of where the NT was 3.8 millimeters a few days earlier. That's why I was asking. Is the patient ready, ji? Patient is ready. That's a third trimester scan. We're going to first show you the biometry, then show you the amniotic fluid index, then we're going to be showing you the color Doppler as well. For doing the amniotic fluid index, you need to always be careful of that you need to be placing you need to be placing your probe like this. It has to be perpendicular to the obstetric table, parallel to the midline. You need to be taking all the 4 quadrants, or which is the other way you can take it, one pocket, the deepest vertical pocket. So just remember that. We're just going to show you that. LMP feed ho gaya ji? The LMP is 6th of July, that makes it 39 weeks and 2 days. Okay. No, thanks, thank you. बच्चा घूमता है पूरा बेटा? No. जली बोतल और चाहिए होगी थोड़ी देर में, बिकॉज अगर 1-2 और है ना हमारे पास, बस हैं, एज लॉन्ग एज कोई दिक्कत. First and eyeballing is, अगर एक और sheet है तो ये ऊपर दे दीजिएगा ताकि इनकी साड़ी खराब ना हो.
We want to know what probe you are using.
We're using a convex sector transducer, that's a multi-frequency. You're going to be looking at C1 to C5. So that's basically 1 to 5. And after I'm through with this case, I'll come outside and discuss how you're going to be and how these frequencies are going to be helping. What's this that we're looking at? That's the cranium that we're looking at. What's this center, that thing that we're looking at over here? That's the thalamus over there. We're looking at the CSP over there, these 3 lines. We're looking at a nice cranium, the skull portion. Can we see the eye sockets over there? Can you see the lens over there? We can see can we all see the lens, Ji? Yes. We're looking at the eyelids. Can you look in at the parietal encephalocele over there?
The ear.
That's the external ear. What is this that you're looking at? That's the hair on the occiput area over there. We're looking in at the spine over there. It does not matter whether you're doing a first ultrasound in the 3rd trimester or in the 2nd trimester, and eyeballing of all the structures is extremely important.
It's little bright on the screen.
It's completely white. Just hold on. Let me just reduce it. Is that okay? Better?
Yeah.
Because now I'm seeing quite a bit of it black, but that's okay. As long as the delegates are comfortable, I'll manage from here. Depth कहाँ से है जी? Depth ये? Depth here. ठीक है जी, आ गया. So this is how you're looking at, and always be careful of looking at the last portion of the backbone. This is the sacrococcygeal area. The moment I'm taking a transverse section, how many ossification centers are you going to be looking at? How many? 3 of them. 2 posterior, 1 anterior over there. What is this that you're looking at on the side of the spine? This is the kidney. That's the other kidney. Which kidney is this? Which kidney is this, Ji? That's the left kidney because I'm looking at the stomach bubble over there. What is this vessel that I'm looking at over here?
Renal arteries.
Those are the renal arteries, and that's the renal artery on the other side. Why is this renal artery appearing red and this renal artery appearing blue? Because this is flow towards the transducer, this is away from the transducer. That's the aorta over there. What are these vessels that I'm looking at over here? That is the hypogastric artery on either side of the urinary bladder. We're looking at the foot over there, we're looking at the hand over there, that's the other foot. What are we seeing over here? I hope the chambers are coming out clear because over here they're a little on the darker side, so I'm not very sure how is it coming there. Are the valves coming out clearly?
You may increase the gain to your comfort, sir. No problem.
No problem, sir. I want everyone over there to be comfortable, and plus the spine is anterior, so we'll hold on, not to worry. Now, which arch is this that you're looking at over here? This is the ductal arch. This is the aortic arch. And why am I saying this is the aortic arch? One, because of the shape. This is what shape? This is the umbrella or the candy cane sign. The other thing is, what am I seeing from the top over here? I can see the vessels over there. And where is it originating from? From the middle of the heart or the anterior portion? From the middle of the heart. So this is the aortic arch over there. Now, which arch is this that you're looking at over here? This is the ductal arch because it's the ice hockey sign, not the hockey that we play. It's coming from the anterior-most chamber, and that is the right ventricle. Which vessel is this that you're looking at over here? That is the inferior vena cava. Anything anybody wants to know, just keep on asking, please, right? We're just going to take the measurements now, and if the baby obliges and the heart comes anterior or the spine posterior, we'll be able to show you the heart. Otherwise, we have a few more cases. How do we take the measurements, G? The BPD has to be measured, how, G? Inner to inner, outer to outer, outer to inner, outer to inner, but nowadays with the latest guidelines they started to say that you can take it outer to outer as well, but we're still following the outer to inner, and you need to be very careful. Set कैसे करना है इससे? हाँ जी, कर लो जी. You need to be careful that it is at right angles to the fox over there. Then you're supposed to be looking at the occipitofrontal. OFD है इसमें जी? OFD है. It has to be from the outer to the outer over here. Then we're supposed to be looking at the HC. HC is here, and that has to involve, I love these machines, they do half your job, Ji. That is how you're looking at the HC, and everything is corresponding to around 36, 37 weeks, which is absolutely fine. Do we need to save it? Then you're supposed to be looking at the abdominal perimeter over there. Is this section okay for the abdominal perimeter?
No.
And why is this not okay? Because the kidneys are there. You're not supposed to be looking at the kidneys. You're supposed to be looking at the stomach. You're supposed to be looking at this J portion over there, the umbilical part of the portal vein, and without seeing the kidney, and you're supposed to be looking at a rounded area over there, that is the abdominal perimeter. What is this that's happening over here? What is moving over here?
Fetal respiration.
That is the fetal breathing movements. How many of you still doing the biophysical scoring? Can we take the abdominal circumference, जी? कैसे? AC होगा? HC, FL, OFD, किधर गया? We are still trying to hunt for the abdominal circumference measurement. इससे set होगा? There are quite a few machines where you can just measure the diameters and it calculates. If you're seeing over here, the abdominal circumference seems to be a little on the lesser side, which we're going to be discussing tomorrow as to the growth curves and everything. Now we're going to be measuring the, आप save कर लो जी. We're going to be now measuring the femoral length. Femoral length there. What I normally do is I measure it not from the epiphysis to the epiphysis, but from the shadow to the shadow, which I find is much more comfortable. Can we show the report page? We're looking at the weight that is 2.2193, 2.2 kgs. So we're looking at But always and always remember, do not give the EDDs according to this. You always are going to be looking at the first ultrasound report, and that's what's going to decide what the EDD is and what is the exact gestational age.
I'm not very happy with the image taken for femur.
Sorry, sir?
Not very happy with the image taken for femur limb.
The measurement or the image, sir?
The image.
Image, okay. That is how you're going to be looking at. This is where you're looking at a shadow over here, you're looking at a shadow over here. Can we see the shadow of the femur there? That's how you're looking at measurement of the femoral length. Right, sir?
Yes, sir.
And whenever we're looking at more than 35 weeks, you're supposed to be looking at the distal femoral epiphysis over there. There you're looking at the distal femoral epiphysis. That's the DFE. That's what you're looking at in terms of the fetal face over there.
Can you show the epiphysis once again, sir?
Sorry?
Can you show the epiphysis once again?
I'll show that, sir. Just a moment. There, you're looking in at the mouth which is opening, the baby drinking fluid, you're looking at the lips, upper lip, lower lip, you're looking at both the nostrils over there, you're looking in at the eye sockets. We're just going to do a short 3D, just try and show you the face as such. They have a 3D probe, and then I'll show you the epiphysis as well. थ्री डी कर रहे हैं 4D कर रहे हैं 3D हाँ That's the umbilical cord coming in front of the nose. Can we just go inside? Translate कर लें अंदर तक और अंदर There. That's the umbilical cord which is giving that impression. In front of the lips over there, we're looking at the chin. थ्री डी कैसे हटाना है बस ना अब वो नॉर्मल करेंगे अभी रुक जाइए लेट्स हैव द नॉर्मल 2D probe. After 35, in fact, the book says after 33 weeks, you're going to start looking at the DFE over there. That's a distal femoral epiphysis. You're looking at the femur over there, and you're going to be looking at an epiphysis just below it. If you see over here, this is where the femur is ending, and that is where the distal femoral epiphysis is there. If you're looking at the tibia over there, you're going to be looking at a proximal tibial epiphysis as well. Again, this is basically to figure out as to how many weeks are we looking at if the patient has come to you for the first time. Because if we take her measurements and it's for the first time she's come, we're going to claim as if she's only 33, 34 weeks. But we know with the way we're looking at the DFE, this is definitely 38 weeks plus. Right, sir? Anything else in this, or we start off with the color Dopplers? That's the DFE, or the distal femoral epiphysis. The moment I get my 2D probe, this baby decides to move the umbilical cord away, and the moment I get the 3D probe, the baby again moves. चलिए जब आप सेटिंग्स छोड़ के फटाफट ये ले लीजिए इससे पहले बेबी फिर हिल जाए Baby obliges. You turn कर दीजिए baby को. Let the baby turn towards Astri. I hope the settings are coming fine on the screen over there, sir.
Yes, sir, very much.
That's all basically software gimmicks where we're trying to put in a torch and see as to how we can. Let's change the. ना इसको थोड़ा सा और कीजिए ताकि लिप्स अच्छे से दिखे सर. ना उल्टा उल्टा उल्टा. There more yeah, that's it. बहुत ठीक है ठीक है. So you can see the impression of the umbilical cord.
Yes, sir.
हाँ जी हटा दीजिए. We'll have the 2D now. Where should you be focusing on the umbilical cord over there, Ji? In terms of, it has to be a free loop, not towards the abdomen, not towards the placenta. And if you see on the side over here, can you see this is the color Doppler over there? You're looking at these are the velocities. So there could be a change in the velocity or there can be a change in the PRF, whichever way it means the same. Can you see so much of blood flow over there?
Yes, sir.
Can you see there is so much of blood flow, this blue over here? That is basically the movement that is happening over there, and that is why you're looking at the flow in the amniotic fluid. Otherwise, this is not actual blood flow, this is not actual umbilical cord. Now, this is umbilical cord that you're looking at. Again, depends on whichever chart you're following, whether you're following the SD ratio, whether you're following the PI values, it's absolutely fine. Finally, what do you need to calculate with the umbilical artery and with the middle cerebral artery? We need to calculate the CPR or the cerebroplacental ratio. And how do you calculate the CPR? It is the middle cerebral artery PI divided by the umbilical artery PI. And usually if I take a ballpark figure, the value should be less than 1, more than 1. It should be more than 1. Over here, again, it's not the PI value that I'm more interested because I normally use the SD ratio. We're looking at over here, that's 3.06, and you can always follow the charts over there. Which vessel am I looking at over here? Oh, sorry, I always use that. That's fine. Can we have this? We're looking at the middle cerebral artery, and normally if I take a ballpark figure, how much should the PI value be? That should also be more than 1. Again, you can always go on to the SOGS charts and figure out at what percentile am I looking at. It normally should be more than 1. If it's less than 1, that's when you're going to start thinking of that there is a brain sparing effect that's starting. I normally follow a manual trace because what happens is supposedly there's any irregularity. If you're seeing over here, I'm seeing these also going up to the 0 value. So I normally would have taken a tracing from here till here and given on the manual trace. But again, depends on how much time we have, how we're following it up, we can easily follow up. Otherwise, you can always increase the sensitivity on the auto tracing, and you see now they've removed the whatever noise or whatever trouble was there, and we're getting a value, though it was almost similar. Earlier it was 1.81, now it's 1.80. But try from your end that whatever best you can look in for. Any questions? Please keep on asking. We're looking at now which vessel over here? Which vessel are we looking at over here? This is the aorta over there that we're trying to look in for. Sorry, I always press the right one. I'm so used to in my machine. Earlier on, we used to give too much of importance to the ductus to the descending aorta. Now we don't, because when the changes in the descending aorta are going to happen and there's going to be plenty of difficulties, meanwhile the middle cerebral artery and the ductus venosus are much more sensitive. Looking at the ductus venosus, you need to be always careful because that's a marker for that you're looking at acidosis happening over there. The best way to look in for the ductus venosus is this. You can either take a transverse section, you're looking at the umbilical vein coming here, there's a branch going to the liver, and the one over here which is going here is the ductus venosus. Where would this be going, G? Straight to the ductus venosus is a conduit which takes this most pure blood to the inferior vena cava. The inferior vena cava takes blood to which chamber? To the right atrium. And from the right atrium, the blood is supposed to flow to the right ventricle. But this, because in the IVC there is a two-stream flow, and this is a much more faster flow, much more speedier flow. So this goes from the right atrium to the left atrium, left ventricle, and the purest form of blood reaches the baby's brain, which is the most important organ. If you see over here, this vessel is much more wider, the ductus venosus is narrower. So what happens is, the moment you're looking at flow from a wider to a narrow pipe or a vessel going, there's always going to be an increase in the velocity. That's the breathing movement happening. And the thing to start off, if you see, the last thing to go away is going to be the last thing to come up is going to be the breathing movement, and the first thing to go off is also going to be the breathing movement. So if you're looking at good breathing movements, you are comfortable that we are not looking at hypoxia or trouble if you do not have a color Doppler. If you have a color Doppler, we have these vessels helping us. इसकी वो भी बढ़ा दीजिए जी, वॉल्यूम भी बढ़ा दीजिएगा अभी, ताकि भी there's always going to be little turbulence at the level of the ductus venosus. This is where we're looking at the M sort of a pattern: ventricular systole, ventricular diastole, and atrial systole. We are always and always interested in this over here. The moment we're looking at reduction in flow, we know trouble is happening. The moment there is absent flow, even worse. And if you're looking at reversal of flow, that means acidosis is set in, and we're going to be having a limp baby with a bad APGAR score. Again, there's plenty of controversy whether the uterine arteries should be checked at this stage or not. Usually in the third trimester, not very helpful because nothing can be done about it. But just for the sake of completion, I'll just show you the Can you see the uterine artery over there? Can you see the uterine artery? What's happened? Nobody's saying a yes or a no.
That is the iliac vessel.
That's the iliac vessel. So whenever you see a triphasic pattern like this, you know you're looking at the iliac vessel. So just be watchful. Don't start labeling it that as if you're looking at reversal of flow in the uterine arteries. Just trying to show you the problems that we can be facing, so you should be well aware of it. That is the iliac vessel that you're looking at over here, and we're supposed to be looking at the uterine artery. मैं हमेशा वो वाली दोबारा हूँ, सॉरी जी. Now, this is the vein over there that we're looking at. Hanji. No notching seen over there, plenty of diastolic flow, so you're comfortable. That's what we're looking at the right side. Even without measuring it, you know you are comfortable there. Sorry? बहुत डार्क हो गया सॉरी जी मैं अपनी तरफ से आप लोगों को बेटर दिखाने के चक्कर में
That's likely to be a branch of uterine artery. Your PSV was hardly 45.
I'll just measure that, sir. नीचे कर दीजिए. This is around 70. This is the uterine artery, sir. That's another very good way that if you're looking at something which is less than 50 centimeters per second, be careful at what angle are you looking at and whether are you insonating the main uterine artery or not. Any questions on this? Do we have a second trimester as well so that we can we have good. So but we're trying to show a third trimester now or a second trimester so that there's something different.
अभी हमें एक fibroid की लेनी पड़ेगी because she came very early.
Would you like to put the Doppler of the placental?
और एक और 36 weeks है उस पे हम बाद में Doppler वगैरह दिखाएंगे.
ठीक है जी वो कर लेते हैं. Sorry sir, you were asking me a question,
Yeah,
sir.
would you like to put the Doppler at the placental base to know?
Sir, I couldn't get the question. Are you asking
is it adherent placenta or not?
The adherent placenta, again, what you're trying to look in for an adherent placenta, I always feel the best way to look in for, if you're looking at an anterior placenta, which is not going up and she's had a previous section, that is the best way. That's, unless and until proved otherwise, it's supposed to be an adherent placenta. Then you're supposed to be looking in for these lakes over there. If there are many in number, if you're looking at a myometrial thinning over there, if you're looking at vessels which are coming perpendicular to them, that is when you're going to be suspecting for adherent placenta. That's the placenta accreta spectrum, the PAS. But if you see over here, obviously she hasn't had a previous section, it's a posterior placenta. You're looking at vascularity. Again, if you're looking at too much of a vascularity is when you're going to be thinking of adherent placenta. If you're looking at a mass which is jutting out, or there's a pouching happening in the urinary bladder is when you're going to be thinking of. This much of vascularity in the retroplacental area with the retroplacental myometrium thick enough, you are comfortable with it. I hope that was the question you were asking, sir.
Yes, sir. Thank you so much.
We're now going to be looking at a fibroid. Any questions from the delegates as well? Anything you want to ask by the time they are settling a patient of a fibroid? You're looking at a fetal weight on the 8th percentile with a normal Doppler. Is that FGR? A fetal weight on the 8th percentile, normal Doppler, is that FGR? That's not FGR. On the 2nd percentile with a normal Doppler, is that FGR?
Doppler has got nothing to do with the FGR. Doppler indices would change afterwards.
Sorry, I couldn't get that.
Doppler would not say whether it is FGR or not.
No, but if the on it's less than the 3rd percentile, irrespective of whether the Doppler is normal or abnormal, it's supposed to be FGR. If you're looking at between the 3rd to the 10th percentile, if you're looking at an abnormal Doppler, that is FGR. If you're looking at Doppler that's normal, you're going to be calling it a SGA, small for gestational age. There could be patients where it could be on the 80th percentile and it's down to the 40th or the 30th. That could also be FGR. That's another set which we're going to be discussing tomorrow because that's the latest thing that's happening. If there is a baby who has a potential of being a 4 kg and it turns out to be 2.8, that's an FGR. That has a potential of going wrong. If there's a baby who has a potential of being a 2.2 kg baby and it's 2.2, it's absolutely fine. There is nothing to worry as such, because the innate potential is what really matters. If there are any questions, please keep on asking. Any questions which I can help out on, please keep on asking, Jay. We are now going to be showing a fibroid as such. When there are no questions, I usually feel there are two things. या तो मैंने बहुत clear कर दिया है, मैंने बहुत confuse कर दिया है, बहुत clear तो मैंने नहीं किया पक्का. हाँ जी. We're supposed to be doing an abdominal scan now. बिल्कुल तब करेंगे, तब तक बीच में एक पेशेंट और देख लेंगे.
जहाँ या बीच में आपको सिखाना रहेगा तो
वैसा कर लेंगे, बिल्कुल ठीक है. Can we have the history of the patient, जी?
Can we also know the history here?
हाँ जी, हाँ जी. Sorry, मैम, आप history बताओ जी.
36 years patient having palpable lump in abdomen and having PV bleeding since last 3 weeks. Having para 3 tubectomized 10-12 years back. Regular cycles up to last 3 months, and since last 3 months having off and on continuous PV bleeding, and LMP is 3 weeks back having continuous PV bleeding for 3 weeks.
Okay.
The moment we have menorrhagia, we have menometrorrhagia. What fibroid is the one that we feel is going to be troublesome?
Submucous.
It's the submucous fibroid that's going to be the troublesome one. So we first doing an abdominal scan. Again, if there's a huge fibroid or there are multiple fibroids, always be careful. Do not start off just with the transvaginal. The first time you are meeting a patient, it always and always has to be an abdominal scan. So now let's quickly revise. What are we looking at over here? That's the bladder. What are we looking at over here?
Cervix.
That's the cervix. We're looking at the uterus over there. We're looking at a fibroid. Which wall is the fibroid?
Posterior.
It's posterior. And how do I know where is the endometrium? If there's any confusion, always and always trace it from the cervical canal, and you'll see from the cervical canal that's where it's going on. This is the endometrium. Can you all appreciate the endometrium?
Yes, sir.
And we're looking at a fibroid which is FIGO what stage? FIGO what stage are we looking at over here? This is basically 2 to 5, where we're looking at starting from submucous till subserous. It's a panmural fibroid, posterior wall panmural fibroid. So I'm supposed to be looking at which wall, I'm supposed to be looking at what type, then I'm supposed to be looking at the echo pattern. What echo pattern is this? Is it hypoechoic, hyperechoic, isoechoic, mixed echo pattern?
On our screen is appearing a hyperechoic.
It's basically a mixed echo pattern. How does it appear now, sir? Abhi bhi white aa raha, sir?
Yeah, no, abhi theek hai, sir.
And then what next do you need to check? It's displacing the endometrium. You can see that. It's pushing it anteriorly.
Yes.
Now what do I need to switch on?
Doppler.
I'm not looking at too much of vascularity, but again, why am I not looking at too much of vascularity? Because what am I seeing over here? What velocity am I looking at over here?
Can't read on the screen. actually.
25 centimeters per second. That's quite a bit on the high side. Can we have it less? So we always need to be reducing it, and now we're looking at, can we see the twigs of there on the
Yes,
of the
yes.
vessels?
Yes, sir.
There. And then whenever in doubt, we have power angio to help us. Can we have the power angio? Can we see a few more twigs over there now? So that's how it's going to. In infertility practice, what is better, color flow map or the power angio?
HD flow.
So we're going to be looking at power angio, and to look in for the direction, we can always and always look in for HD flow, to look in for endometrial vascularization, to look in for perifollicular vascularization. Can we go back to the color? You want to show something else? HD flow dikhana? Again, though this does not seem to be something like a leiomyosarcoma because of the now, why is this appearing? Why am I looking at why am I looking at a black band on top of the baseline? Because it could be because of a faulty filter as such. Always and always be careful. It does not matter in this case, but supposedly if you're looking at an umbilical artery and let's say the filter goes even bigger, you'll be mentioning as if you're looking at absent and diastolic flow. So just be a little more careful whenever you're looking at the baseline. The amount of vascularity that I'm seeing over here does not seem to be the one of a leiomyosarcoma. That is something we need to be always and always a little watchful for. What type of a vascularity am I seeing over here? Is it, idhar wala waveform thoda idhar le aaiye. There. Is it a low impedance flow or a high impedance flow? Just by looking at the waveform. Waiting for answers. Is this diastolic flow showing you a low impedance flow or a high impedance flow? This is a high impedance flow because you can see the systole, and in terms of the diastole, it seems to be almost 1/4 of it. Can we take the measurement, G? I'm looking at a resistive index of 0.69. I'm looking at a PI of more than 1. When you're looking at a resistive index of less than 0.40 or a PI less than 0.70, 0.75 is when you think of low impedance flow, especially for fibroids. Any questions on this case? We're going to be doing a transvaginal on this, but honestly speaking, we're not going to be able to see too much because this fibroid is quite a big fibroid, big uterus. We're not going to be able to see the fundus too clearly, but we'll just try so that then we can show you. Always and always in such cases, try and look in for the ovaries. Which ovary are you seeing over here? Which ovary is this, right or left?
Left.
This is the left ovary. And in those cases, even if you do not see the bladder, you are going to be going through the fibroid and trying to hunt for the ovary over there. That is the other ovary. Can you appreciate the right ovary? The right ovary?
Yes, sir.
The left ovary. So whenever you're doing it, and a report is never a good report saying right ovary not delineated or left ovary not delineated. Now what does that mean? Has it been taken out? Because then how do you say whether it's normal or abnormal, and what is the surgeon or the gynecologist going to be planning, the laparoscopic surgeon? So we have to do our bit whenever you're doing an ultrasound. Wait. Tissue दे दीजिएगा. TVS में कुछ आएगा नहीं, but अगर करना है तो कर लेंगे. जैसे क्योंकि it's quite a big one.
If we have any other case for TVS, we need not do TVS in this case.
Do we have a patient for a TVS otherwise? Do we have another patient for a TVS otherwise? So then we'll do a TVS on this one.
What was the measurement of this fibroid, sir?
So then we'll do a TVS on her so that then we can just demonstrate.
Sumit?
We're doing a TVS on her, sir, because there's no other patient for a transvaginal.
Okay, sir.
So we're doing it on her. By the time she's going to go to the loo and come back. If there are any questions, you're most welcome, Jay.
Yes, people are asking the size of this fibroid.
Size of the fibroid, I don't think so it's been focused properly, but yes, this is around, this seems to be the complete uterus over there being measured.
Fetal head size.
See, this big normally is not supposed to be an adenomyoma. The best way to differentiate is if you're looking at an adenomyoma, you're not going to be able to see the margins very clearly. It's going to melt inside the... Then apart from that, if you're looking at the myometrium in an adenomyotic uterus, you're going to be finding the other things, the salt and pepper appearance, the myometrial cysts over there. There could be a radial ray pattern. All those things are going to be there. In terms of vascularity, a fibroid is going to be showing you more of a peripheral vascularity unless and until there is degeneration. In an adenomyoma, it's going to be more as if a river is flowing through them. It's just passing through them. That's how you can. But there are always those overlaps. There are always those gray areas. So many times when you mention something of a submucous fibroid, it turns out to be an adenomyoma, and that can be really troublesome during a hysteroscopy.
This fibroid particularly didn't show any peripheral vascularity on transabdominal.
It was showing a little bit of peripheral. It was showing central as well. That's because of the degeneration. But this one, we are not even doubting it that this could be an adenomyoma because this has clear-cut margins. Any other questions? In obstetrics, gynae, infertility, how many of you doing IVFG? Plenty. And how many of you are in terms of doing ovulation monitoring? Let's come on to that. How many of you are doing ovulation monitoring? Plenty. So it's not necessary that for an IVF you need to be looking for endometrial vascularization or perifollicular vascularization. You can, for your routine cases also, for your IUIs also you can. So in terms of the ideal endometrial vascularization, how much do you feel is an ideal vascularization? If I talk about zone 1, 2, 3 or 4.
Zone 2.
Zone 2, we normally prefer zone 3. It should be an inner zone or a cavity vascularization. The zone 2 would be more of an outer zone. And in terms of perifollicular vascularization, how much do you feel is a proper one where you should be giving the trigger?
3/4 with a peak systolic more than 10.
More than 10. So if you're looking at a peak systolic velocity more than 10 centimeters per second, you're looking at more than 50% perifollicular vascularization, you're comfortable that yes, you can give the trigger. Why I'm saying is it's not only for when you're looking at an IVF, if you're looking in for your IUIs also, if this is not happening, you can always and always tell them to come back again the next day and then you give a trigger and you would be getting much better results. Now, how do you calculate the perifollicular, the peak systolic velocity? Because that's always angle dependent. So if it's going to be angle dependent, how are you going to calculate 10 centimeters per second? Because if you change the knob, even if it is 6, it will become 12 or it will become 18 or become 20, or if it's 20, you can make it 4. So how do you do it?
Keeping the angle as parallel to the vessel.
You don't need to be looking at the angle correction because you're doing a power angio. In a power angio, the angle is not needed. That is why I always say for a perifollicular vascularization, for endometrial flow, always and always use power angio. You do not need to do any angle correction. Right? Any other questions on infertility?
We also need to measure the uterine PIs.
The uterine artery PI, that has to be done with a color flow, and the ideal value should be that it should be less than 3. You're going to be finding a notch. Because if it's more than 3, then you need to be very skeptical. There are plenty of you who are doing your embryo transfers if you do not get a good vascularization. Because in those cases, you don't need the ovarian flow. You need the uterine flow. If you're getting a good zone 3 vascularization, if you're getting a uterine artery PI which is less than less than 3. If you're looking at a multi-layered or a triple-layered pattern, you are looking at an endometrium which is more than 7. Ideal would be between 8 to 10. You are comfortable about it to do the embryo transfers, to give the triggers if and when needed. Right? Do we have the transvaginal ready, Ji? The patient ready? Do we have an early pregnancy? हो गया क्या? Fine. Before we start off with the transvaginal, हाँ जी. It's not basically the gains, it's the velocity. The PRF, the pulse repetition frequency, should be less than 0.3. There are machines which can get it till 0.3, the power angio also, but if cannot, the least that you can get from your machine, do that. Lower the velocity as much as you can on a power angio. So that's the best way. So whatever vascularization you'll have to make do, because everybody can't be changing the machines and it's not needed as well. So for the perifollicular, for the endometrial, the PRF has to be till 0.3. But in some machines it comes till 0.6, till 1, that is also fine. Any other questions? Please feel free to ask any number of questions. हाँ जी.
Sir, do you want gloves? Gloves?
No. हाँ जी, नहीं, मैं थोड़ा सा और, so that she should be comfortable. आप ही डाल दो ताकि वो comfortable. मैं डाल दूँ? बेटा loose छोड़ दो बच्चे, बिल्कुल loose. You need to be very watchful. You need to be very gentle. क्या करना था? ना मशीन आगे नहीं करनी, कुछ नहीं करना. When I'm introducing the probe, should the image be in a frozen mode or a defreeze mode?
Defreeze.
Defreeze mode, right? Now, how do I decide what is anterior? This is anterior, this is anterior.
The top one.
Because I'm looking at the bladder over there. I'm going to be increasing the gain, sir. I hope it does not come out too white over there.
No, sir.
I'm going to increase the overall gains. Depth और थोड़ा सा, depth कहाँ से करते हैं, sir? हाँ, depth बढ़ाना. ना, उल्टा. जी. Perfect. Now, उसको वापस वैसे ले जाओ, sir, जैसे किया था. So now can you see the endometrium clearly? You can see the normal anterior myometrium, and we're looking at a fibroid.
Yes, sir.
We're looking at the posterior surface as well, showing up very nicely. We're looking in at the cervix over there.
Yes, sir.
Whenever in doubt, always come from the cervical canal, and you can see whether if it's going posterior or it's going anterior, so that you're clear of which wall is the fibroid, so that we don't make a mess of it.
Can you just show us the TGC setting which you are using for TVS?
The TGC settings, sir?
Yes,
the
sir.
thing is, the TGC settings, I'll just explain that, how do you really need to be doing it.
Yes, sir.
Because showing you on the screen over there, sir, because it's becoming very white, so that's why I'm darkened the image at my place. That happens with the screen or with the projectors. But this is how you're looking at vascularity. I'll just, in a transabdominal, I'll demonstrate. Otherwise, what I'm looking at over here is this portion of the screen. This portion of the screen, we have like 1, 2, 3, 4, 5, 6, 7, 8. We have 8 knobs over here. So divide the screen into 8, and if I'm going to be looking at an ultrasound wave going here, it's going to reflect back. It comes here, it's going to go back. Comes here, it's going to go back. So what is going to happen is, which wave is going to have the best reflectivity, A, B, or C? The A is going to have the best. It's going to be losing. Whatever is going to go here is going to come back, but whatever is going till here is going to be lost because of There's going to be diffusion, there's going to be gases, there's going to be tissue over there absorption. So what we need to be doing is to get a uniform image. I need to make the upper portion a little more darker, the lower portion a little more brighter, and that is where the TGC helps me. That is where the TGC tells me so that I get a uniform image. I hope that's what you were asking, sir?
Yes, sir.
So, because otherwise, if I'm going to have a straight, let's say I have a straight setting, let's say these are the TGCs, I have a straight setting. So the upper portion is going to be the brightest, the lowest portion is going to be the darkest. If I need to have a proper one, I'm going to have the upper knobs a little to the left, the lower knobs a little to the right, so that I get a proper uniform image.
Yes, sir.
And whenever you're doing an ultrasound and you want to be looking at the depth, be careful that you are, कैसे depth कैसे ऐसे करते हैं जी? You can see the depth over there, 16 centimeters. Is this depth correct that I'm looking at? I'm unnecessarily telling my machine to work till here and go back and study. I just need 2 fingers below this is more than enough. All these values over there, over here, mean a centimeter each in of these. So that is how I need to be careful. This, if you're looking at over here, is 16 centimeters. Just see this. I don't know whether it's appearing or not. Are you able to see? Now it's 15. Now it's 13. So this is absolutely fine. I didn't have to tell my machine to work till 16 centimeters. It works till 13 centimeters and comes back. When you're not using your machine, should the probe be kept in a frozen mode or a defreeze mode?
Frozen.
Frozen mode. Because unnecessary, why should it be firing? And we tend to get worried after 9 months or after 1 year. Why isn't my probe not that efficient? It's because you've not been using it properly. Should I always keep a jelly blob on the probes, or should I wipe it once the scan is through?
Wipe it.
It always has to be wiped on. One, so that it remains clean for the patient, next patient. Second, otherwise the mouse or the mice are going to be eating up your probe, and we're going to be again in a deep soup. Thank you. Thank you, जी. कैसे रखना ऐसे?
हम एक नेक्स्ट 32 वीक्स वाली लेने वाले हैं।
ठीक है जी।
उसके लिए ना 3-4 क्वेश्चंस जो ऑडियंस ने पूछे थे वो लिख के लिए हैं। एक तो वो प्रीवियस एलएसीएस है तो उन्हें स्कार थिकनेस का थोड़ा बहुत जानकारी चाहिए। एएफआई तो आप डेमोन्स्ट्रेट किए,
बिल्कुल।
वापस हम एक बार देख लेंगे। ट्रांस सर्वाइकल लेंथ लेना रहता है या ट्रांस एब्डोमिनल?
ये अभी आप मेरे से पूछते चलिएगा, उसी टाइम पे एक माइक ले लीजिए आप भी और पूछते चलिएगा। अच्छा।
सर उसके एक आउटसाइड रिपोर्ट में लेफ्ट परसिस्टेंट एसवीसी करके आया है हमारे करके आई दिस पेशेंट।
ये
Can we know what discussion is going on behind that curtain?
सर हम लोग देख रहे हैं, हम लोग पीछे से चुपचाप कैसे भाग जाएं सर? They were telling me what all are the 5-6 questions that are going to be asked. So I was saying, just ask at that time itself when we're demonstrating it. So they're just preparing a patient of 32 weeks. And we're going to be demonstrating. I think so there are quite a few questions that have been written. Otherwise, anybody can just yell out and ask a question.
Yes, sir.
सर को दे देती हूँ क्वेश्चन।
हाँ जी, ये यहाँ पे इधर से पूछ लेते हैं।
यहीं से पूछ लेंगे नहीं तो।
यहाँ ना साथ के साथ ही पूछ लेंगे और उधर सर बाकी सारी चीजें पूछते जाएंगे। It's 33 weeks and 2 days. She's had a previous cesarean. There was a question as to how do we measure the scar thickness. To be very honest, it's usually not done now because if I do it with a small parts. We have a small parts probe here also, so that really increases the sensitivity. But I've always seen it's usually more of a clinical one where you're looking at for scar dehiscence is what's most important. What they've done very nicely is they filled up the bladder as well, which is a good sign, so that then I can differentiate it between the bladder wall. We're looking in at the cranium over there. We're not going to be taking the measurements again, we've already taken. Can we see a profile? Can we see the baby is almost set for a selfie with the pouting over there?
Yes. Probably thirsty too.
That's also possible, sir. We're looking at the lips. We're looking in at the jaw over there. You can see the alveolar ridge over there. Can you all see the alveolar ridge?
Little bright here on the screen. So
Bright? Okay, let's reduce it.
perfect, perfect.
So we're looking at the jaw over there. You're looking at the eye socket. You're looking
Yes.
at the lens over there. You're looking at the lips, the
Yes.
nostrils. I go inside the lips and I'll be able to see the alveolar ridge over there, the tooth bearing area. And that's the mandible, the maxilla and the mandible. There, that's the baby's hand over there showing a Babaji ka thullu. We're looking at the feet over there. There was a question, how do we measure the amniotic fluid index? I'm supposed to be keeping the hand which is perpendicular. I'm going to be looking at all the 4 quadrants. That's 1.
But are you still following the 4 quadrant?
Sir, there are plenty of us who are following the amniotic fluid index 4 quadrant, or usually we're preferring the deepest vertical pocket, sir.
Yes, sir.
And now when we're measuring it, it has to be the deepest vertical pocket in each of the quadrants when we're measuring. What do we need to exclude?
The cord.
So then should I measure it like this?
No.
Because we're looking at the cord. Whenever in doubt, you can always switch on the color as well. Yes, Ed Bhattanaji? It has to be perpendicular. If I take either of the deepest vertical pockets here, the deepest vertical pocket, the total is 125, which is fine. If I take the deepest vertical pocket, that's 36 millimeters, that's also fine. So either ways, the Leica is normal for this stage. We're looking in at the spine over there. I hope it's not coming too bright over there, or have I the permission of
Setting
making
is
my
perfect.
image a little bright here?
Yes, sir. You can make it clear bright if you want to.
Is that okay?
Yes, sir.
Looking at the kidneys over there, looking at the kidneys. Again, this patient also has, the baby has the spine anterior. Again, obstetrics means patience, and you need to be very, very patient with these babies. You cannot be presuming that this would be normal or this should be normal because you're seeing something of an indirect sign. Always and always be very, very careful. Haji. What structure am I seeing over here?
GB.
That's the gallbladder over there. And is this placement okay? The gallbladder, the portal vein and the stomach, is that okay? That's the way it's supposed to be. There would be a few cases where you're going to be looking at the gallbladder in between these two structures. It's basically this one going this side. So that is a normal variation, not that it's something abnormal, but if you're seeing it, you should definitely write it in the report. If you're looking at these avillus areas, do not have to worry unless and until they're showing vascularity inside. If these avillus areas are not showing vascularity and they're not connecting to the anterior portion over there, you are comfortable. That means you're not, because she's had a previous scar, that means you're not looking at a placenta accreta spectrum over there. You're not looking at too much of an increased vascularity over there, you're comfortable. You're looking at these vessels which are parallel to the uterine surface over there, you are comfortable. The moment you're looking at these vessels, especially more so in the scar area, you're going to be uncomfortable. Secondly, the placenta has gone up far away from the scar area, again you are comfortable. Hanji, there were a few questions. Scar thickness, I'll try and show it to you with the small parts probe. AFI I have demonstrated. Measurement of cervical length. Well, the transvaginal scan is always and always the gold standard, especially at this stage. But this is how you're going to be looking at. The good thing is the bladder is full, so you can look in at the internal ossia. If you see, this is the vagina portion. The moment it gets broader is the cervix. The moment the cervix gets broader is the uterus. So if to make do with the cervical measurement on the transabdominal, how do we take a single measurement, Ji? This is the set button. You're going to be taking it from the center over there to the center over here, 3 centimeters, and we're comfortable. In fact, if you're looking at 32 weeks, even 2.5, 2.6 would not be that bad as such. So a partially full bladder consisting of 80 to 200 ml of urine is comfortable. That's how you're going to be looking at. That's the cervical length. Ideally, if there is some problem and I need to be looking at a cerclage or something, I would be doing either a translabial or a transvaginal scan. Next question, Ji.
Significance of an absent diastolic in MCA. Sometimes if you get a...
See, if you're looking at an absent end diastolic in the middle cerebral artery, to be honest, that's not significant at all because we're worried about only absent flow there. What usually happens is, it could happen because of 2 reasons. One, if you're pressing the cranium too much, one, or if the mother hasn't eaten for quite a long time. So just hold on for a little while, again call the patient back again, and you'll be comfortable looking at flow in the middle cerebral artery. Absent flow in diastole in the middle cerebral artery is nothing to worry. What have I done was, I was pressing the cranium a little bit. पीछे जाओ जी, पीछे जाओ.
Exit कराने बाहर.
पीछे, पीछे जाके, और पीछे, और पीछे. There. There. Did you see? This is when I was keeping the cranium a little compressed, there was absent flow. Gradually I've released the compression, and that's where you're looking at. Are you able to see that?
Yes, sir.
So those are the few things that you need to be careful. हाँ जी. और कोई question इसमें?
Are you taking the
Last क्या है जी? अच्छा.
probe for the scar again?
Do we need to report the cord around the neck?
Again, when we're looking at cord around the neck, there was a talk which I had given many years ago that we are not very sure of whether the cord is around the baby's neck, the parent's neck, the ultrasound wala's neck, or the gynaec or the obstetrician's neck. So that is why we stopped mentioning it, because again, if you're looking at 2 loops or more, that is when I mention it. Otherwise, I gently mention it to the patient that just be a little more careful in terms of movements. You just scare them up in terms of saying that this could happen and that could happen, and then next day they stop feeling movements. So we need to be a little careful about that, not to panic, not to scare them. Now, I'm going to be looking at the scar area. If you see over here, can you see the scar nicely?
Not really.
Even I can't see it, sir. So that's why, that's why we're going to be looking at on a small parts probe. Do we have the small parts probe attached, Ji? And we're looking at the abdominal. Do we have an abdominal one, or you can? Do we have a TAP view where we can get that? Ah, perfect. Now, if you see over here, the exact scar area that you're looking at, you can see over here. If you're looking at something which is hypoechoic, that basically means the scar area is showing a muscular healing, which is the good thing. If you see it's going to be hyperechoic or echogenic, that is more of a fibrous healing, and that's going to give way. So that's how you're supposed to be looking at this measurement, not including the bladder, not including the...
The picture is moving a lot, so we're not able to...
No, sir, I'm trying to focus it, sir. I'm just going to focus it there. Can we now see the picture?
Yes, sir.
There you're looking at, this is the portion. This is the calculations. Again, depending on what all charts or what all books you are looking at, this is what you're going to be. You're not going to be including this portion, it's going to be this portion. And getting a scar of 4.8 millimeters, fair enough as such.
How did you make out that that's the scar?
But it's basically just below where we're looking at the scar, or what I normally do is I measure the thinnest portion, sir.
Okay.
That is because that is what we're concerned with. Is it getting thin or not? So the thinnest portion which I see with my linear probe is the area that I normally measure. But again, irrespective of what we're doing, if I get a phone call from the OT, that means hell is broken loose. Kuldeep, you had mentioned this much and it turned out to be this much, and I could see the fetal hair also. So that I always feel, and then I have to, after the surgery is through and after 2 hours I have to call up that I had seen the patient 4 weeks ago. How can I say what's going to happen 4 weeks later? So the fight continues. Ji.
So what is your final advice on should we be going ahead with the scar thickness?
Scar thickness, I've stopped mentioning it, sir. I always say that there is no point because it's more of a clinical diagnosis. Now with this probe, can you see over here? What am I seeing over here? That's the spinal cord. So with the small parts probe, you can see the spinal cord nicely. So if somebody has had a problem or somebody said a meningomyelocele, it's always better to get it checked with this. Can you see the spinal cord?
Yeah.
Again, things are getting better, we are getting smarter, the machines are getting better, Ji. So that's how things are working out. Can we see the tuft of hair on the back side of the head?
Yes, sir.
Any questions? Oh, thank you. Any questions on this? Or we can ask the patient to get up now?
I can ask the patient to get up, but this is $1 million question from many delegates.
Sorry, sir?
There is $1 million question from many delegates, which machine to buy?
Ek second, sir. Ji. Sorry, sir. I'll come outside and ask, sir.
Yes,
I couldn't
yes.
understand the question, sir. Abhi 1 second lita ke rakhiyega. Ji.
Bilkul.
Ji, sir. Haan ji, sir. There was a question.
Sir, which machine to buy is $1 million
Which-
question.
आप चेंज करो जी मैं फिर तब तक
One
तो
which
नहीं ये नहीं
suits to
patient
your
देखना.
pocket.
Which machine to buy? The best is, that's what I say, they're going to kill me. The best is, whenever you're buying a machine, make sure there's one machine wala sitting inside and 3 of them sitting outside. That's the best. You'll get the best deal.
One which suits to your pocket.
Sir, when there are 4 of them, then they're themselves going to fight and give you the best price. So that's why I said, one has to be inside and make sure when he goes outside, there are 3 of them. तो अपने आप ही सबसे अच्छे रेट्स मिल जाते हैं, then you can bargain, because once you've sold the machine, then you're going to be bargaining for the machine has gone bad, so how much are you going to be charging us? Hanji, any other questions? What patient do we have, जी? मैम एक काम करिएगा ना, ये वाले पेशेंट को थोड़ी देर के लिए बिठा दीजिएगा, बिकॉज स्पाइन पर अगर वो तैयार होते हैं तो, नहीं तो फिर कोई बात ही नहीं. Again, whenever you're looking at doing a scan, never compromise, because I was about to burn my fingers. There was a patient in which the baby wasn't moving this side, and I could just see a little bit from the side. Okay, call them back again, come back tomorrow. They came back after 2 weeks. And it turned out to be, when the baby turned this side, it was binder facies. So always be very careful. So, and whenever you're writing something, it's not always that the court of law is going to decide. It's for our good also. Always mention if you've not been able to see something, so that it's there in the report. No, I will check it. Muzabani, it does not work. It does not work. Everything has to be written. So mention it, so that next time if anybody else is seeing, they can see it for you, or you know it whenever it's there. Or if you have your notes on, mention it there in the notes itself. What is the next patient, ji? 28 weeks. We're waiting for a spine to go posterior, then we'll demonstrate the heart as well nicely. Sorry, that's the commonest question I ask everybody, what is a level 2 scan? Anybody of you doing level 2 scans? Asking for level 2 scans? सबको डर लग रहा है कैच है कुछ इसीलिए पूछ रहा है. What I'm trying to say is there's nothing like a level 2 scan. There is nothing like a level 2 scan. You cannot say that I've done a scan and I've not done a level 2, so I'm authorized to miss an anomaly. That's never there. If you've done a scan, whatever has to be checked at that time has to be checked. If you're giving a report, it has to be. So there's nothing like a level 2, level 1 scan. It's an anomaly scan, simple, that is done after 20 weeks or 18 weeks. You need to be having that much of a thing that these things have to be checked in for. We have a 28 weeks. What are the other patients we have?
So right now we have a break of inauguration.
Okay.
So even you can rest for a while.
So you can take a rest.
Not a resty rest, sir.
We now move on to the inauguration of the workshop. I request Kuldeep Singh sir, Dr. Dabde sir, Dr. Ajit Gandhi sir, Dr. Sumit and Dr. Virkar sir to come forward for lamp lighting. Also Dr. Meena and Dr. Khare, please join. Dabde sir and Dr. Ajit Gandhi sir, please come forward. Sir, yes, ये तो हाँ सर आइए. Dabde sir, please join us.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा. वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा. वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा. प्रथमेश्वरा गणेश्वरा प्रथमेश्वरा गणदेश्वरा चिन्तामणि परमेश्वरा गणनाथ सुरमणि गणपति।
I request President Dr. Virkar sir to please felicitate Dr. Singh sir. I request Virkar sir to felicitate our moderators, Dr. Dabde sir. Dr. Ajit Gandhi sir. Dr. Sumit. I also request Dr. Virkar sir to felicitate Dr. Meena Gunjatikar. Dr. Madhura.
Dr. Praveen Khare. Dr. Ketki Joshi. Break. We will have a short break of 10 to 15 minutes and we'll start again. You are invited for delicious snacks.
Preterm normal delivery and now 28-week pregnancy.
Any specific indication for the scan or for the workshop you have got her?
For the workshop.
Okay, thank you.
Hello, caller mic is not working.
Hello. Yeah. Can we have Dr. Sumit ji?
Sumit?
And ये वाला लाइट थोड़ा सा डिम करा दे.
करवा दीजिए। आपका माइक चल रहा है सर?
हाँ जी, हाँ जी. So we're looking at a breech presentation. We're looking at the placenta over there. Can we have the lights dim, ji?
Please, lights dim, please.
Can we see the mouth opening and closing, and can we see the tongue moving inside?
Yes, sir.
Is the TGC fine there, sir? It's not too bright.
Absolutely fine.
Can we all appreciate the nasal bone over there?
Yes, sir.
That's the nasal bone, that's the maxilla, that's the mandible. But there was a question during the break over there as to how do we follow up the nasal bone. Well, not at this stage, but in the NT scan, we have to make sure that the nasal bone is more echogenic than the nasal skin as such. That is when we call it that the nasal bone is normal. Otherwise, we have those various charts where we can look in for how much is the nasal bone size. Can we see the nostrils over there?
Yes, sir.
The nostrils, we're looking at the lips over there, we're looking in at the maxilla, that's the alveolar ridge again, we're looking at the mandible. We're looking at the ear, the external ear over there. Can we see something here?
Yeah. Corpus.
That's the corpus callosum. What are we seeing over here? That is the cerebellum. What is this that we're looking at over here? The tentorium cerebelli. And what are we seeing over here? That is the pericallosal artery. Can we all appreciate the pericallosal artery there?
Yeah.
So the moment we're looking at a pericallosal artery, we're looking at a corpus callosum, we know we're comfortable, we're not looking at agenesis. You can always go in for this view also, there you're looking at again. When you're looking in at this portion, what are you looking at over here? This is the Sylvian fissure over there. What are we seeing over here?
Cerebellum.
That is the cerebellum. What do we see posterior to the cerebellum? Cisterna magna. These are the cerebellar hemispheres. That's the cerebellar vermis over there. We're looking at the fourth ventricle here, not dilated, which we're comfortable. This ahead is the third ventricle, again not dilated, and that's the cisterna magna. We come on to evaluation of the heart over there.
Can you show the anterior and posterior complexes?
We're looking in at the four-chamber view of the heart. Can we see what is this that we're looking at over here? This is the foramen ovale over there. We're looking at the chamber closest to the spine is the left atrium. We're looking at the mitral valve. That's the tricuspid valve. We're looking at the ventricular septum. This is what we call a lateral four-chamber view. This is the apex of the heart. This is the base of the heart. If we're looking at the apex this side, then we will be able to see it again, but the only problem is we could be looking at a dropout, or it could appear as a ventricular septal defect. If we're looking at the base anterior, we had it, then it's very difficult to look in at the heart. Can I have the cardiac one so that then I can show it nicely? Can we all see the heart nicely? Can we see the cardiac four-chamber view?
Yeah.
Then the moment I am going like this, I need to be looking at the outflow tracts. Which valve is this? This is the pulmonary valve. Which valve is this? This is the aortic valve. Now, what am I demonstrating here? I am looking at an aortoseptal continuity. The ventricular septum is continuous with the anterior wall of the aorta. So this is aortoseptal continuity. The mitral valve is continuous with the posterior wall of the aorta. This is not supposed to be a straight line. It is supposed to be making an angle like this, which is absolutely fine. So we're looking at a four-chamber view. We start off like this, and we're looking at almost a five-chamber view, where the fifth chamber is the start of the, or the root of the aorta. Now what am I looking at? Which view is this? We're looking at a three-vessel view: pulmonary artery, aorta, superior vena cava. That's how you're going to be looking at. So what happens is there is this crisscross relationship which has to happen with the outflow tracts. Pulmonary artery like this, aorta like this.
What is this vessel that I'm looking at, which is going posterior to the aorta and the SVC? This is the right pulmonary artery. We are looking at the pulmonary artery, aorta, superior vena cava. What is this that I'm looking at? This is the trachea over there. These two vessels have to be on this side of the trachea and the SVC on the right side. If I'm looking at this going towards this side, what would that be? That would be a right aortic arch. I'm looking at an SVC over here and I see another SVC over here. What would I call that as? Persistent left superior vena cava. So again, don't feel that the heart is difficult. It's just that you need to get onto a hang of it. And you need to be getting the best position. That's why when the spine was anterior, didn't comment on the heart. When I got a favorable view, that's when I started commenting. This is the short axis view of the heart, where I'm looking at these chambers. You can again look in at the outflow tracts. We're looking at the, which arch is this? This is the aortic arch. The moment it gives us these three branches and before it enters the ductus arteriosus, what is this vessel over here? What is this vessel over here after the branches are given off? This is the aortic isthmus. I am looking at this V sort of a pattern. The end of this V is the ductus arteriosus. The end of this is the aortic isthmus. And we need to follow the basic two principles. The eyes are going to see what the mind knows, and secondly, if anyone can do it, you definitely can do it. You need to be confident about that. We are looking at a bicaval view. This is a reverse hammock sign, where I am looking at the SVC, the IVC. This is the right atrium. What chamber is this? What chamber is this? The posterior most chamber is the left atrium. So this is the left atrium. You need to have the anatomy correct and there will be no problem at all. We are looking at the ribs over there. What bone is this that we are looking at? That is the scapula over there. We are looking in at the clavicle over there, or the collarbone. What is this that we are looking at over there in front of the three vessel view? This is the thymus over there. See that subtle demarcation, thymus till the thymus. This is the lung, this is the lung. If you're looking at a thymus hyperplasia, that's when you're going to be thinking of the various deletions and the various smaller syndromes. Which organ is this that we're looking at? That's the gallbladder. Then there was a question about looking in for, can we go on to the normal one? Looking on to the pelvic ileal dilatation. This is, I am supposed to be measuring the pelvis. Okay, then like this is okay. Why this is not okay, either of the two? Because it's not to be taken in a longitudinal section. It always has to be taken in a transverse section. And then be careful, whenever you're looking at renal problems, you have to see whether it's unilateral, bilateral, whether you're looking at just the pelvis that's dilated. Is it pelviectasis? Is it pelvic iliectasis? Is it a ureteric dilatation also? looking at the echo pattern of the kidneys and the thickness of the renal cortex. What I normally follow is less than 4 before 20 weeks, less than 6 before 30 weeks, and less than 8 before 40 weeks. That's how I remember it. But the book says up to 7 millimeters is fine till 26 weeks, and more than that, it should be less than 10 millimeters. But whichever book you're following, this is basically how much is the value here? 2.2 millimeters, which is absolutely fine. Around 28 weeks, we are comfortable with it. Where is the B? The B is here. Anything specific that you want to ask about this?
Yeah, there is a question as to can you demonstrate the midbrain?
The midbrain, that we're looking at, that's the thalamus portion. Otherwise, normally what we've done is they're basically these three things that we're looking at. Which section is this? Longitudinal, coronal, or transverse? Or axial that we say. This is an axial section. So this is the transthalamic plane. This is the transventricular plane. And we're supposed to be looking at the parieto-occipital sulcus to take the lateral ventricular measurement. Can you see the POS? The POS on the other side. And then the third section is the transcerebellar. So transcerebellar, transventricular, transthalamic, and nowadays we have started doing these sections where I started off first by looking in at the corpus callosum, and you can do a coronal section as well. Looking in right from the face area, start going back, and you will be able to see all these areas. You can see the lens over there. You can see the eyelids over there. You all have eaten something and you haven't offered the baby anything. Looking at the punch again. Anything else in this patient? Anything, sir? We can ask the patient to get up, Jay?
Yes, sir.
Wait, post दीजिएगा जी. It's basically, you need to be patient with these babies, you need to be following them up with the scientific protocol, and things never go haywire. We'll be able to do it. तसल्ली से पूछ ले बेटा, इनको टिश्यू और दे दीजिएगा.
Would you ever comment on the placental maturity?
Placental maturity, sir, we were earlier grading it into 0, 1 and 2, but we've realized it. We just have to mention when it's homogeneous and when there's a problem as such, when you're looking at too much of calcification. Now, because of the advent of color Doppler, in fact, for so many years, we've realized it does not matter, even if we're looking at calcification, as long as the Dopplers are fine. It's just that if at 32 weeks I'm looking at dense calcification, I'm going to be asking for a Doppler a little more frequently than I would otherwise ask for.
Thank you, sir.
आराम से बेटा गिरना नहीं, आराम से. बच्चा आराम से. इसको देखते कि मुझे डर लग रहा है अभी गिरी अभी गिरी. हाँ जी मैम. Hi, please. Hi, ma'am. हाँ जी बिल्कुल.
While you are changing the patient, is one query. If there is, once you notice that there is a pelvic ileal dilatation, what more things we are expected to look at in the urinary?
I'll come out and answer that. अभी patient तो नहीं है ना? ना, बस ठीक है. हाँ, I'll come out and answer that, sir. हाँ जी, sorry, I couldn't get the question, sir. जी.
Once we notice that there is a pelvic ileal dilatation, quite a significant, say 10, more than 10 mil, whatever classification you follow.
Right.
What additional observations you are expected to put in the report about the urinary tract?
Not only the urinary tract, I would be worried about if I'm looking at just a pelvic ectasis, I'm going to be thinking of it as a marker for Down syndrome if I'm doing an anomaly scan. So I'm going to be looking at all the markers. It's not that it's just the, when I see a pelvic ileal or pelvic ectasis that I'm going to be looking at. What all could be the markers for Down syndrome? Thick nuchal skin fold. Let's start from up. Choroid plexus cyst.
No, forehead is not a marker for 21.
Choroid plexus cyst is more for trisomy 18, but choroid plexus cyst now they say for Down syndrome also you need to be careful. That's why I specifically said that. Echogenic intracardiac focus, but again that's a very soft marker and it's taken as a normal variation. Looking at pelvic ileal dilatation, clinodectally sometimes they say it. Looking at ventriculomegaly, when we looking at let's say ventricular fullness as such, when we say it's borderline, we're supposed to be. When you're looking at clubfoot, sometimes they say you should be, otherwise clubfoot is normally for, if there are many other markers for 18 and 13. Then you're supposed to be looking in for if there's any major anomaly like a VSD, an AVSD, looking at duodenal atresia, you need to be watchful. So when I'm doing looking at pelvic ectasis, I'm going to be looking at the complete checklist. And I always say it's not that I need to remember these 6 things. I'm going to see from top to bottom if there's any other anomaly, as simple as that. If I'm looking at, as sir rightly said, hydronephrosis, when I'm looking at pelvic ectasis, I'm going to see where exactly could be the site. I can never always pinpoint, could be the site of obstruction. One, whether it's unilateral or bilateral, whether I'm looking at a bilateral PUJ obstruction where there'll be no ureters dilated. Let's say unilateral or bilateral, if I'm just looking at a ureter dilated, whether I'm looking at over distension of the urinary bladder, whether I'm looking at dilatation of the proximal urethra, those are the direct features that I need to see. Now to look at the function of the kidney, what are the indirect features that I would see? The liquor, if it is bilateral. If it's unilateral, the liquor will remain normal. Then I'm going to be looking in for the echo pattern of the kidney and the thickness. What happens is gradually the kidney becomes a little white. So when it becomes a little white, you'll find that the dilatation has gone down, you'll be happy. No, be careful, it might be the kidney stopped functioning. So be very careful on that. If you're looking at a very thin one, that earlier it was hydronephrosis, now it's becoming a multicystic dysplastic kidney, then again I'm looking at trouble. So these are the indirect and the direct features that you're going to be watching out for the moment you find dilatation in the urinary system, right? हाँ जी मैम, आपने कुछ ना अभी कुछ और करना है उसके बाद
वो एक फेलिसिटेशन कर लेंगे जो आए थे ना
बिल्कुल बिल्कुल बिल्कुल
Sir, how often do you see dilated loops of colon and
dilated loops of colon, especially in the 3rd trimester? Sometimes you're going to be seeing it, but those are normal as long as you're not looking at hyperperistalsis. Sometimes you see a hypoechoic one, you don't have to worry. The moment we see a hypoechoic, we tend to, but in the 3rd trimester, it's quite often that you can see such a thing. But if you're not looking at too much of movement, if the small bowel is more than 7 millimeters or the large bowel is more than 15 millimeters and you're looking at plenty of peristalsis, that is troublesome, otherwise it's not.
We have with us PCNDT cell coordinator, Mrs. Shama Dabir. I request Dr. Virkar sir to please felicitate her.
Thank you, ma'am.
जिनको हमने पेंडिंग रखा था ये 32 वीक्स
वो देख लेते
उनको देख लेते हैं.
So we have another 32 weeks and then we have an anomaly scan.
So that 32 weeks left.
बिल्कुल बुलाइए.
Repeat.
हाँ 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 जी.
So we have a 32 weeks, then we have a 20 weeker,
इनके बाद है.
and then Dr. Sumit is saying there are another 20-30 cases.
Sir, here is a question.
हाँ जी जी.
What is the significance of echogenic liquor?
Echogenic liquor. Echogenic liquor, basically we used to earlier worry about fetal distress. That is when we didn't have color Dopplers. But if you're looking at, I've burnt my finger so many times because if you're looking at echogenic liquor, so echogenic that you could see the umbilical cord, then there is nothing to worry because in terms of if the color Doppler is normal, you're not looking at fetal distress. That's usually more of Wernicke cystosa. So that is why we are now not worried about echogenic liquor as long as the Doppler parameters are fine. But when we didn't have Doppler, the moment you used to see echogenic liquor, deliver the baby. That's meconium. That's what we used to think. We have a 32-weeker which we've seen earlier, but it's just that we're trying to look in for if the heart shows up nicely.
Any specific history of this patient?
This was the one with the previous cesarean, sir.
So again, scar thickness.
No, that we've already demonstrated, sir.
Okay.
Baby doesn't plan to oblige too much. It's because they were seeing something in the cardia and we're trying to just see if we can. But the baby refuses to oblige. Again, when you're looking at, this is the spine over there at the 12 o'clock position. That's the most difficult plane to really look in for the heart nicely. Would be wrong on my part to really label it, though they've told me what exactly this could be. We're looking at a P, A and S over there, but that's another vessel and that's the left, persistent left one which they've mentioned. But to be honest, unless and until I see it properly, but yeah, I can see another vessel. Can you see that? Close to the pulmonary artery on the other side. Again, one of the benign things as such, nothing to worry, nothing to be done about it. And when we're looking at 32 weeks, as it is, we cannot be doing anything about it. Can you all appreciate another vessel? Apart from these 1, 2, 3, there's another one over here. Can you see that? So that seems to be that only, but again, I would be much more comfortable if I'm looking at something which is with the spine posterior. We've troubled her enough, so we can't let her wait more. Let's see, is the baby obliging? डॉक्टर सुमित लग तो रहा है लेकिन
ठीक है सर मतलब अभी जैसे आपने बताया 32 हफ्ते हैं
nothing has to be done and as it is even if it is there nothing has to be done पेट पोछ लीजिएगा जी
So whether it be first trimester or anabolic scan, you want the baby to look at your probe.
Sorry, sir?
Whether it is NT scan or the anabolic scan, you want the baby to look at your probe.
Yes, absolutely, sir. But if we want to look at the spine carefully, sir, we want the other way, that the baby should be going the other side. So it's just that we have to keep praying and making sure that the baby obliges, sir. Or otherwise we have to keep feeding mamas lots of ice cream because summers are here. So that really helps. हाँ जी और क्या लास्ट पेशेंट है वही देखते हैं जी we're getting an anomaly scan. So what I'm going to show is what all do you really see in an anomaly scan or so-called TIFA scan, and that's how we're going to be planning.
That's what everybody is waiting for.
Yeah, we're going to be showing that. अभी तो नहीं इकट्ठे होना सब लोग पहले वो कर लें उसके बाद हाँ They're just settling the patient. Any questions meanwhile? Anybody wants to ask? Anything on ultrasound in OBS, gynae and infertility which I can help out? You're most welcome to ask. We've spoken about the uterine arteries in the first trimester. If you're doing it in the anomaly scan, the uterine arteries, how much would the value be, the mean uterine artery PI? Should be less than 1.5, that's a ballpark figure. And in the third trimester, how much should it be? Less than 1.17. So that's how we take it. In the first trimester, less than 2.5. Otherwise, if an abdominal scan less than 2.35, second trimester 1.5, third trimester less than 1.17. In obstetrics, where would you need angle correction? In the middle cerebral artery. And if we do an angle correction, how is it going to help us? The middle cerebral artery diastolic flow helps us to decide about brain sparing. And the systolic flow lets us decide about anemia. And when do we call it anemia? When it is more than 1.5 moms. So that is, when it's more than 1.5 moms, it tells us that we could be dealing with moderate or severe anemia. Mild anemia we never worried about. So that is how. Aage sir? Patient aa gaya?
About the uterine arteries,
Sir.
so other maternal factors and other risk factors are to be taken into consideration. What is your opinion about that?
So nowadays they've started giving us.
Alone at the uterine artery,
That is sensitive, but not that as sensitive when we are looking in for the PLGF, for the maternal age, for mother's blood pressure. All those things are always going to be there. So that's how things are helping us.
when we look at the artery, these are also to be taken into consideration.
Absolutely,
to
absolutely.
increase the sensitivity and specificity of the PIH prediction.
That definitely goes up. How many of you are asking for PLGFG? For the placental growth factor, how many of you are asking in the double marker test? Are you asking for it? Because that's how they started on for the penta screening in the first trimester itself. So that's how it helps us. So again, things are getting better. We have to every 6 months or every 1 year come up with something smart ताकि सारे busy रहें, ताकि बार-बार हम लोग को सोलापुर बुलाया जाए. That is it.
Well, sir, about the PLGF, since you are asking about,
Sir.
we had done extensively about the PLGF in our cases. And what we have noted is it creates more confusion than it clears the picture. It's the maternal risk factors and properly taken uterine artery is more reliable and more sensitive than using the markers for various reasons. And that is what we have been following now.
So in a place like Delhi, we are almost asking everyone now. We meaning I don't ask for it because I'm a sonologist, but otherwise the gynecologists, normally they are asking for the PLGF in almost all cases. So they are asking for PAPE, beta HCG and the PLGF. So all those things are combined and then both sides blood pressure is taken. In fact, I was attending a conference that day and they told me how to take the blood pressure also they were telling. So but that also there's plenty of art in that how to take the blood pressure of the patient. So that is also there. So
if you look at the FMF guidelines, now even they have taken out the PLGF from their protocol.
Yes.
They are using the PAPE and the uterine artery along with the risk factors to calculate the preeclampsia risk. So PLGF probably may not stay longer.
It's quite possible, sir. It's quite possible. That's what I'm saying. Every 6 months or every year, there's something new which comes on. We start following that, and then. So the thing is, we emulate the West, and then we come on to it. But we definitely need to have plenty of Indian charts and Indian standards. And then might be we all are getting smarter. Might be we come up with a new compound that okay, this is going to be much better because our scenario, our conditions are different from the Western guidelines, right? I'll just start off with a patient over there.
Can we have a group photo right now before?
Whichever way you say.
Yes. Because this is the last case.
ठीक है जी.
Sumit, what is the next case? Anomaly scan.
We have strict instructions or something, ji.
Now this is the last case what we will be having of anomaly scan. But before that, since it is a memorable day for us with so much of delegates present today, so we need a group photograph before everyone disperses. So first we have a group photograph and then we move on to the last case. I request everyone to please come forward near the stage for the group photograph.
Aaj sir, aaj.
Hello.
Yes,
सर सबको धक्का देना पड़ेगा सर कोई नहीं उठ रहा.
There is an announcement, some red color car of MH31 1417.
कैसे हैं सर?
Very nice. Very nice.
Thank you so much sir.
yes, sir.
Hi sir, please.
He is my classmate.
सर आप बैठिए सेंटर।
अरे सर
सर आप बैठिए।
सर प्लीज आप लोग
नहीं, सर भी बैठेंगे आपके साथ। सर प्लीज।
सर पहले बड़े बैठे सर
आप बैठिए पहले। सर यहाँ
आइए सर आइए प्लीज आइए सर प्लीज आइए सर प्लीज
बलदाव सर।
मेन कोट है सख्य
करें सर।
अरे नहीं हो बलदावा सर ना बस यस सर आता पार्क मध्ये
हॉस्पिटल में गेलो सिद्धू वाले होतो ना बाबा डॉक्टर वाले त्याची बायको लोवर
Residents also can join, please.
काय म्हणतात एवढं फिरवले
सर जो उधर से नहीं आ रहे फोटो खींच लीजिए रैगिंग करेंगे सर
हम लोग नीचे बैठ जाते हैं पीछे नहीं होगा खाली एक राउंड करूंगे
कसे गमतीत आणि काय होतं आज वर्किंग डे आहे ना सगळे लोक येते आपल्या प्रॅक्टिसवर बिझी असतात
भरपूर रश आहे
चलो जी सारे सांस रोक लो
This is for the memory of Dr. Virkar and his team.
लास्ट वर्किंग डे
सर एक मेरे कैमरे से भी खींच लीजिएगा प्लीज
मोहन एकदा सांगा आणि मग फोटो घ्या
हां मॅडम
माझा
म्हणजे पोट आत
गुडघ्यावर बस
नाही हे
Yes. Okay. Cheese.
Yes. 1 minute. One more smile. Yes.
थैंक यू थैंक यू खींच लिया बच्चे
टेबल आहे की
हेलो
सारे हिले कुर्सियां गायब हो गई
थैंक यू ऑल फॉर अटेंडिंग इन ह्यूज नंबर
Sir, while demonstrating anomaly scan, please demonstrate how to
Thank
measure
you,
the
sir. Thank
ventricles also.
Yes.
Ventricle.
Definitely.
How to take the measurements from which point to which point, ventricular.
Done, sir.
All right, sir.
So we have the anomaly scan now. So that's the last patient where you can ask questions. So please feel free. Ajay Sumit. Before I start the scan, can we have a huge round of applause for the complete team for getting such nice and good patients? Thank you so much. Thank you.
That was from your side. Now from our side for you.
Can you see so much of fetal distress? Can you see the echoes in the Leica?
Nothing. Nothing on the screen as yet.
Nothing on the screen? क्या हो गया? हिल गया क्या सिस्टम? नहीं मतलब कुछ भी नहीं आ रहा स्क्रीन पे सर?
नहीं आ रहा है.
भाई देखो जी जरा कौन सी तार हिल गई?
हम खुद को ही देख पा रहे हैं.
वेट सर. सर फिर तो बेस्ट फोटो आ रही है सर. हो गया? अब सर एक्कोज आ रहे हैं?
नहीं सर, नहीं, नथिंग ऑन दिस. मोहन काही येत नाही बघा.
HDMI ओके आहे मशीन.
जस्ट गिव देम 1 minute.
नाही वाच. तिकडचंच आहे.
जैसे ही आता है मुझे बताइएगा सर.
आ गया.
आ गया
कहीं भी
सर?
रहा. टाटा भी कर रहा है.
सर हाई दिख रहा है सबको?
Yes sir.
That's from baby side to all of you saying a hi. ये देखिए सर, ये यो कर रहे हैं सर. Can you see the first and the fourth finger?
Yes sir.
That's the yo coming up. Baby's getting in a party mode for the evening. We're looking at the placenta. We're looking in at the cranium. Now, the zoom portion, you need to be very watchful. It's not only that you're looking at the zoom portion only for the NT scan. I'm looking at the, that's which view over there for the cranium? The transthalamic view. You're looking at the complete cranium, you're looking in at the thalamus there, you're looking at the CSP, you're looking in at the lateral ventricles there now. Can you see the lateral ventricles? And whenever you're planning to measure the lateral ventricles, I hope the screen is coming out fine, sir. Not too bright, not too dark.
Perfect, sir. Perfect.
अब आप ना छेड़ो सर ने perfect कह दिया. अब आप ना छेड़ो सर. Now you're looking at the lateral ventricle over there. What is this white area that you're seeing over here? This is the choroid plexus. Whenever you're planning to measure, now you can see over here, I'm just trying to first show you things. This is the anterior horn, this is going to be the body, and this is the posterior horn. Are you supposed to be measuring, though this is not the correct section, are you supposed to be measuring from here to here? Because that's what we used to do 10, 12 years ago. So you're not supposed to measure till here. You're only supposed to measure the lateral ventricle. You're supposed to be measuring, when I'll show you the correct plane, from this to this. Inner to the inner has to be measured. Now I'll show you which is the section or the point where it is to be measured. This is the parieto-occipital sulcus. And whenever you're seeing it on one side and it is normal, do you need to see the other side? Or when you feel it is okay, ek taraf to dusri taraf bhi theek hoga? You're supposed to be doing it. So this is the parieto-occipital sulcus. You're supposed to be measuring from the inner to the inner, and it has to be perpendicular. This is 5.9 millimeters, perfectly fine. This is the parieto-occipital sulcus. You're supposed to be measuring from here to here. 5.3 millimeters, fine. Up to 8 millimeters is normal, 8 to 10 is borderline, more than 10 millimeters is when you call it ventriculomegaly, more than 15 millimeters is when you call it severe ventriculomegaly. Anything you want me to repeat again, you are most welcome to ask me any number of times. Then, can you see the cerebellum?
Yes, sir.
That's the cerebellum. You are supposed to be looking at how many cerebellar vermis are there. There's one cerebellar vermis, or are there two? There are two cerebellar vermis, inferior and superior. So you need to rock the probe. It's quite possible that you just focus one and you're going to be looking at the superior cerebellar vermis when the inferior cerebellar vermis could be deficient. You're measuring the cerebellar hemispheres, the transcerebellar diameter. I'm looking at 19 millimeters, so how many weeks do I presume the fetus would be? 19 weeks. So from 14 to 22 millimeters, the measurement in millimeters is equal to the weeks of gestation. Somebody conceives in lactational amenorrhea, not sure of her dates, comes to you for the first time, you are going to be taking the CTD as the best bet. What is this that I've measured? That's the cisterna magna from the back portion of the cerebellar hemisphere to the inner portion of the occipital bone. That is, and again the same way as the lateral ventricles, this is going to be up to 8 millimeters normal, 8 to 10 borderline. More than 10 millimeters you need to be watchful now. For what all things? You need to be seeing, is the cerebellar vermis deficient? Is there a connection between the cisterna magna and the fourth ventricle? So that's how you're going to be differentiating between Dandy Walker, megacisterna magna, Blake's pouch cyst, and the works. We'll not go into all those details, but just a general format. Now, what is this that I'm focusing on? Or what I'm going to be measuring now? This is the nuchal fold thickness, 4.1 millimeters, perfectly fine. 14 to 18 weeks, up to 4 millimeters normal, 4 to 5 borderline, more than 5 millimeter you need to be careful. We have all those percentiles, but then again you can't be sitting on the computer. By the time the baby will move away and run away. Then from 18 to 22 weeks, up to 5 normal, 5 to 6 borderline, more than 6 millimeters you need to be careful. You're looking at the Sylvian fissure, you're looking in at the face over there. Can we see the lenses? Baby staring at us. Ki Hanji, when are you going to be sending me back home? In fact, I feel all the delegates must also be staring at me like that. There, look at the lips over there. Looking at the nostrils. Can you see the nostrils? That's the other lens. Again, once you've seen one area, always and always see the complete stuff. If the baby is moved away, be patient. Can you see the mandible and the maxilla? And then be careful there, that's the tongue moving over there, that's the baby swallowing. You need to be focusing on, can you see the equal to sign over there? That's the uvula over there. You're seeing at the last portion of the soft palate. I'll show that again. Can you see that? Can you see the equal to sign? The baby is going to swallow and you'll see this increase and decrease in size. You're looking at the spine over there. Anything that you're trying to focus in the anomaly scan has to be focused in 3 ways or 3 views. Which view is this? That's the sagittal view. Which view is this? That's the transverse or the axial view. And which view is this? That's the coronal view. So we're trying to look in for all the 3 ossification centers. The coronal view is going to help us to look in for any hemivertebra or osseous spurs. Can you see the orientation? Once you've seen like this, you know you are not looking at any kyphoscoliotic deformity. Can you appreciate all that? आवाज नहीं आ रही जी, चले गए सारे.
Yes, sir.
Can you see the spinal cord over there?
Yeah.
You feel so happy seeing these things, but again, you have to devote sufficient time, and if you're busy, then it's better that we need to be someone else to be doing it. Can we see the renal arteries both sides?
Yes.
Can you see the kidneys over there? We're looking at the stomach. We're looking at the gallbladder over there. If you've seen, we've been able to see the gallbladder in almost the cases. How many of you are looking at gallbladders in your scan? Let it be anomaly or otherwise. All of you looking at? That's the ear over there that you're looking at. There's so many times where you're looking at a deformed ear, so just be watchful. And always mention it to the patient that you're going to be able to see only one ear. In this case, we are able to see because we're not able both sides because the baby is lying with the face downwards. Can you see the corpus callosum?
Yeah.
Again, not going into too many details, but if you're looking in at the cerebellum over there, can you see that?
Yes.
This is the cerebellum. This is the tentorium cerebelli. What is this that you're looking at? This is the brainstem. We're going to be looking at the medulla oblongata. So there are plenty of signs where you're going to be looking at how much is this cerebellum lifted up. In this case, it's not lifted up, so we know it's normal. Again, just apprising you of these things that we've started to do so that we are comfortable. Well, any clubfoot deformity here that you can see? If you're looking at the sole of the foot and you do not see the tibia and the fibula, you know you are comfortable. Can you see the tibia and the fibula?
No,
we're not. So we're looking at the sole of the foot, not necessarily that you have to see both of them in the same manner, in the same time. If you're not able to see the tibia and the fibula, you're quite confident you're not looking at a clubfoot deformity. We're looking at always and always see for all the long bones. Even if you don't measure it, always see them. If you've seen here, both the feet were at the same level, so you're sure of that there's no unilateral shortening. So you're comfortable. Look at the humerus, radius ulna. It just takes you 60 seconds to see both sides. Humerus, radius ulna.
Yes.
Tibia fibula, and we're looking comfortably. Always looking for the lowest most portion of the spine. I don't know whether this is a high or this is a buy over here. Anything else that anybody wants me to show in this patient? You're most welcome. Otherwise, let's just focus on the uterine artery.
Would you not routinely measure the cervical length?
Cervical length, sir, I would appreciate if she has a little more full bladder, but otherwise I know it's not a short cervix as such.
No, I mean in the protocol would you measure?
Yes, always, sir. The distance of the placenta, that's the placenta over there. We've looked in at the cervix over there. Always make sure that while you're doing, because a proper scan with measurements is almost going to take half an hour, 45 minutes, and by that time the patient's bladder also fills up, so we're comfortable. थोड़ा सा वो बढ़ाइएगा वेलोसिटी ताकि मेन यूट्राइन आर्टरी ही दिखे. बढ़ गया. Just trying to tilt my probe so that then I can get a proper way. That's the uterine artery on the right side. Sometimes you're not able to see it on the right as such. When you slide your probe, go on to the left side, tilt your probe. That's what I've done this time, and I've been able to see it. And I'm going to go on the right side and tilt it. She's a very thin patient, which is very good for a workshop. So that's the left uterine artery. So we're comfortable about it, Chi. Anything else you want me to show? Can you nicely see the ductal arch over there? That's the ductal arch coming out from the right ventricle. What valve is this? This is the pulmonary valve. Can you see the ice hockey sign over there? Perfectly fine over there. Again, once you start doing it, you're going to be comfortable that things are not that difficult as we were presuming earlier. You just have to get into a habit of doing it. Anything else anybody wants me to demonstrate?
Trying to look for DV?
That's, I'm trying to see the DV, sir. The DV can be seen either in the transverse section or you can see it in the longitudinal section. Again, with the spine posterior is always much more comfortable. That is again the M sort of a pattern that you're looking at.
Could you see the kidneys transversely again with the mild pyraclasis?
There, we're looking at the transverse, you're looking at both the kidneys on each side of the spine. Can you see that?
Yeah.
And if I measure it, though, if you see just sometimes on a longitudinal scan, you'll see as if there's plenty of pelvic ectasis. But if you're seeing over here 2.1 millimeters, 2.2 millimeters, perfectly fine.
Just for the, could you show the suprarenals?
The suprarenals, if you see over here, you're looking at the suprarenal over here, there. That's one side. This is on there. Can you see that suprarenal?
Yes, absolutely.
But if you see on a transverse section, go a little higher up and you're going to be seeing suprarenal, suprarenal. Can you see the suprarenals both sides?
Yes.
Again, we used to attach lots of importance for suprarenals there.
Yes.
You're looking at a hyperechoic center and a hypoechoic periphery all around.
Yeah.
We used to attach lots of importance in our third trimester scans when we didn't have color Dopplers. We used to feel if the suprarenal is much more thicker in terms of more than 6 millimeters in the third trimester, those could be indications for that you're looking at fetal distress. That's a nice thumbs up over there.
Good job done.
Yeah. Baby is also happy with the performance. Both sides.
Absolutely.
Baby is very happy with the moderator, sir. All the hard work has been done by Sumit and I'm just narrating out over here. There you're looking at both the clavicles over there. Can you see both the clavicles?
Yes, sir.
Ribs over there, scapula over there. You feel so happy while you're doing a scan and the baby is posing, you really feel very comfortable. You're looking at the mucus plug over there with the bladder filling up a little bit. You can see the mucus plug.
Yes. Very nice demonstration, sir. Everybody's really happy.
Thank you so much, sir. Thank you.
मेजरमेंट ले लो क्या?
कोई और तो पेशेंट नहीं है?
नहीं सर.
So that was the last patient. Any questions? You're most welcome. Anyone to ask you? I can show off my coat now.
Meena, vote of thanks.
I thank Dr. Kuldeep sir for a wonderful demonstration. Hello. And I also thank Dr. Sumit sir for coordination. And I am grateful that all patients and their relatives, they are patiently staying till the end. Thank you all the patients. Without them, it was not possible us to
Applause for them, Ji. Applause for them.
Live demonstration for them. And I thank you both moderators keeping the audience live. Thank you, sir. And I thank you all society members for attending this CME in huge number. Thank you all for today's CME. Tomorrow,
Thank you so much.
tomorrow we are arranging Shirol course oration. Topic is vascular indices and impedance through the trimester for prognosis, diagnosis and management in FGR. We will start, and tomorrow we have at 9 a.m. annual general body meeting. Oration 11:15 a.m. Please kindly attend tomorrow's road course oration also. Breakfast is there also. Breakfast and lunch is there tomorrow. Today we don't have dinner.
डिनर आहे आपल्या आपल्या घरी